Yeah, okay. So, hello everyone, and welcome to day three, session three of the first annual Neuro-Oncology Symposium organized by the Pakistan Society of Neuro-Oncology. I, Imran Qureshi, am your host for this session. We are honored to have Dr. Shehzad Shamim as the session chair with us today. Dr. Shamim is a consultant
Imran, your
neurosurgeon.
video, your video is not on. Can you turn that on, please?
Yeah, sorry. Right.
Okay, thank you.
So we are honored today to have Dr. Shehzad Shamim as the session chair with us today. Dr. Shamim is a consultant neurosurgeon and chief of services for neurosurgery, neurology, and psychiatry. He's also the inaugural director of surgical neuro-oncology and Dean's Clinical Research Fellowship Program. We have an esteemed group of speakers for today's session. If any of you have questions for our speakers, you may ask them on onlinequestions.org by entering the number 13419. Without further ado, I would like to invite our first speaker, Dr. Tom Mickelson, who will be talking to us about cancer genome atlas and data science in neuro-oncology. Dr. Tom Mickelson is a neurologist specializing in the field of neuro-oncology and precision medicine. Currently, Dr. Mickelson is the president and scientific director of Ontario Brain Institute and co-director of the Hermelin Brain Center. Dr. Mickelson?
Good morning. Thank you so much. Colleagues, I really appreciate the opportunity to speak to you this morning. What I intend to do is to talk a little bit about some of the lessons. Dr. Enam, of course, trained at the Henry Ford Hospital in Detroit, and I know you heard from my first chairman, Dr. Mark Rosenblum, yesterday. I think the philosophy of how one manages collaboration and team science in the current era speaks volumes about how we can make progress for the treatment of brain tumors. This has been illustrated through our own contributions in programs like the Cancer Genome Atlas, which was a worldwide collaboration for genomic science in glioma. And I'll talk about some other examples that have come out of this and where it's leading now in the context of next generation clinical trials. So what I intend to do, as soon as I can advance the slide, is to talk about the Henry Ford Hospital contribution to the Cancer Genome Atlas as an example of team science and international collaboration, as the really first major step in the molecular era, following on from the cloning and the sequencing of the human genome. The first major cancer that was sequenced was glioblastoma. There have been some very important impactful outcomes from TCGA-informed research, both at the Hermelin Brain Tumor Center in Detroit, but also around the world, with many, many hundreds of papers making use of this shared data resource. Some specific examples from Henry Ford that I'll talk about a little bit are this ability to look at next generation genomics in the context of liquid biopsies, and the biological significance of extracellular DNA amplification coming from our laboratories. Then I'll talk a little bit about what the role of contemporary genomics is in neuro-oncology and lessons that we've learned from other cancers, such as lung cancer, for which there are dozens of targeted and actionable mutations. And finally, given the plethora of new treatment strategies, how we take this back to the clinic for impactful clinical outcomes. Traditionally, of course, as many of our old-fashioned clinical trials were designed around the average patient. Remember, the statistics that are reported from clinical trials are about median outcomes and median survival, not individualized. This one-size-fits-all approach, of course, is really anathema to anybody that treats glioblastoma, because we know there are even such a thing as favorable glioblastomas, with survivals which can be measured in decades. It's not the norm, but it's certainly the example. And we've become better at defining prognostic groups, even in glioblastoma. In the current era of targeted therapeutics, many of the therapies are extremely costly, and we want to make sure that we enrich patient populations and maximize the response likelihood given these limited resources around therapeutics. This has been well seen again in lung cancer and other systemic cancers, and is really just coming around to glioma. In the context of glioblastoma, of course, we have a limited number of major successes. We know that this tumor can be extremely aggressive with median survivals. Again, there's that median number measured in months. But we do know that there are outliers as well. This is one example of a young woman who had an early recurrent glioblastoma tumor And she recurred 6 months after her initial therapy with maximum safe resection, external beam radiation, and temozolomide chemotherapy. On her re-resection, however, she was referred to our center and had surgery and was identified to have one of the few actionable mutations, which is the deletion mutation of the epidermal growth factor receptor. We happened to have a clinical trial targeting this very receptor with an immune therapy strategy, and she had a very successful outcome in the absence of any additional chemotherapy and did well for over 30 months. Again, anecdote for sure, but proof of concept or proof of principle are things that guide our ability to then generalize through other clinical trials, this time using markers such as the EGFR V3 mutation as a selection marker to enrich populations. And we'll come back to that tactic or strategy towards the end. So this concept of precision medicine is, of course, what we have always intended to do, which is to make sure that we get the right patient, the right treatment, at the right time. This has had its biggest impact, as you know, in the context of lung adenocarcinoma, where tyrosine kinase inhibitors have been now rolled into standard of care pathways with molecular diagnostics as a standard, especially for recurrent and later stage disease. The idea is that even the costs of molecular testing are saved not only by improved long-term outcomes, but refining the patients that are optimal for certain drugs. And this choice is something we hope to deploy in the context of glioblastoma. So how do we do that? Well, the first strategy was to then combine the horsepower at that time, which was the genomic horsepower at the National Cancer Institute, to do pan-genomic testing, including the technology actually changed during the conduct of the protocol, but it started off with large sequencing arrays, initially even with Sanger sequencing, as next-gen sequencing was just coming online at this time. But eventually the program finished with a series of whole genomes in the context of normal and tumor. Now, the original Cancer Genome Atlas was a competitive grant that was initially granted to MD Anderson. The MD Anderson Cancer Center, of course, is one of the largest brain tumor programs in the world, but their biorepository, as they came to find, was not able to sustain the volumes of patients and specimens that were necessary for this project. That was due to a couple of factors. One had to do with the quality of tissues that they've been saving, and the change of SOPs were necessary to ensure that they weren't saving just random specimens and largely necrosis, which had been part of their initial collection. The Henry Ford group stepped in, and we ended up contributing more than 30% of the specimens for the entire Cancer Genome Atlas, both for the glioblastoma cohort and also the lesser glioma cohort. As you can see, this has now been executed on 33 different cancer types with publicly available data that's widely distributed around the world and has been subject of thousands of papers. The initial landmark papers, which started off in the description of glioblastoma, were in Nature. This is way back in 2008. And the major lesson from this early foray into molecular diagnostics in glioblastoma was that the vast majority of glioblastomas, over 95%, had mutations in one of 3 major signaling pathways that, of course, are now well known to us all. The mutations actually did vary a little bit, but if you were able to look at the signaling trees that we're familiar with, mutations can happen in various steps, but over 95% of patients, tumors, harbored mutations in one of these 3 signaling pathways. These are now druggable in many, many opportunities, but this is the first foray into that type of large population-based screening and characterization of the molecular underpinnings of glioblastoma. Now, several other platforms were done, and don't pretend to look at detail of this image, but the point is that there are many other molecular platforms, including expression array testing by RNA-seq, DNA methylation patterns, and as you can see, as the masses of data enlarge, patterns emerge at the highest level, and much work has been done to characterize subpopulations based on multidimensional analyses of different data types. Several seminal observations in the context of glioma biology have come out as a result of this. One of them, and this was not originally a TCGA observation, but one that came out of a parallel program at Duke, but was verified in TCGA, is the role of the IDH1 mutation in glioblastoma. The IDH1 gene was never known to be a cancer-related gene, but has been subsequently found to be functional in leukemia, and especially in many types of glioma, in particular low-grade gliomas and so-called secondary glioblastomas. It has important prognostic significance and is actually a major triage point now in molecular diagnostics, codified by the WHO. And we'll talk about some potential therapeutic applications in a few moments. With these multidimensional data types, we've been able to characterize many subtypes of glioblastoma. And if you think about it in the context of doing clinical trials, the biggest difficulty in assessing a therapeutic response comes if you have a very diverse set of outcomes. If your survival curve trickles down over time and the outcomes are very heterogeneous, it's very, very difficult to tease out a therapeutic response. With many of these molecular features, now we can refine prognostic groups and study those groups in isolation where the outcomes are much more uniform. And that makes it much easier to define outcomes in that more uniform cohort. Some of these have been codified into diagnostics, others are still exploratory. So the details are still under active study. As I mentioned, there are several major triage points, one of which is the presence or absence of that IDH1 mutation. The vast majority of the conventional older adults with glioblastoma are IDH1 wild type. However, if you have a patient that's in middle age or younger, and the IDH wild type assay, which as you are surely familiar, is an immunohistochemistry assay for one specific mutation, these younger patients would be subject to next-gen sequencing to identify other canonical mutations in the IDH1 or IDH2 genes, which can be found in another subset. Certain clinical trials will come to, are defined, we'll talk about specifically the IDH wild type group as being the largest, the most in need, and the largest unmet medical need population that is now the subject of specific clinical trials. Now, there are other diagnostic genes that have been codified, as you can see in this diagram, which includes the mutations of histone genes in the midline gliomas, et cetera, et cetera. So a lot of detail. The point is that we have now become much more specific in our ability to prognosticate treatment groups. Many of these have actually then resulted also in companion both diagnostics, but also therapeutics. And this has been codified in the 2016 World Health Organization classification of gliomas of the CNS. And you'll see several branches, which start off with the earliest known mutation early in the ontology of the ontogeny of tumors, which is that IDH1 mutation, and then the acquisition of other changes after that in the lower grade gliomas, which can include the deletion of chromosome 1p and 19q, either by fusion or by arm deletion. That defines the group that has now been codified as oligodendroglioma. The ATRX loss and TP53 mutations are characterized then as the diffuse astrocytomas. Both of these lower grade gliomas do harbor IDH mutations in common, but they're distinguished by the presence of that 1p19q co-deletion in the oligos. This is then done away with the intermediate group of the oligoastrocytomas, incidentally, as you'll notice. Now, there are a group also in the middle, which are the IDH1 wild type, even by next-gen sequencing, lower grade gliomas. These are a pretty unique group in a younger population and portends a very aggressive prognosis, much more similar to glioblastoma than lesser grade gliomas. So these are often considered so-called molecular glioblastomas, even if they don't harbor the conventional histology of necrosis as seen in conventional glioblastoma. One of the other advantages of some of the huge volumes of data that have come and the populations is that there's very sophisticated high-end analysis of the tumor ecology. So we've become being much more sophisticated in the identification of populations of cells, their variant signaling abnormalities, but also their intersection with the normal microenvironment, including the neuronal population. Some very, very interesting research talks about the supportive communications happening between neurons and glioblastoma cells. And then, of course, there's the entire immune network that we'll come back with shortly. The point is that higher order, very sophisticated network analyses are now enabled by these extremely large data sets in large populations. And so we can start to look at some of the signaling pathways and some of the evolutionary pressures that are resulting in the progress that, as we know, happens between low-grade glioma becoming secondary glioblastoma. So this biology is enabled by this, not yet specifically therapeutically targeted, but this certainly will come. Sorry, that was, apologize. So the era of targeted therapeutics, as you know, is widespread in systemic cancer. We have relatively few examples in glioblastoma and none that have been approved because of therapeutic trials. But I think the idea is that the large data sets that have result from the Cancer Genome Atlas and other derivative research have now created new therapeutic hypotheses, new therapeutic tactics and strategies that are now being deployed in the preclinical models and deployed then into the clinic. Incidentally, this is happening in the context of massive cohort studies that are testing not just brain tumors, not just cancer, frankly, but even normal populations and other comorbidities. The All of Us program in the United States is a precision medicine program of a cohort of 1 million patients that is accrued probably about 25% at this point. Henry Ford does happen to be one of the coordinating centers for a regional network of institutions. But the point is that all medicine now has the ability to leverage these massive data sets and the data science around the biology of disease, comorbidities, and patterns of care and how we influence that. I mentioned earlier that the IDH1 mutation has been characteristic of lesser grade gliomas and the secondary glioblastomas. There have been some early, in fact, outcome published, in fact, this year about IDH targeted therapeutics in the context of certain advanced gliomas, which is very encouraging. It's early days yet. IDH1, as you know, is involved in the Krebs cycle, was never known to be an oncologic related gene, but is in fact involved in the epigenetic control of gene expression by methylation. And there's some very interesting biology around this, but is now evolved into the clinic. One of the other technologies that have been derived from the initial observations from the Cancer Genome Atlas are one of the issues we have, of course, in CNS tumors. If you have a drug, we have relatively few studies where we can actually give a drug and look at the engagement of that drug at its molecular target in situ in the brain, because we tend not to operate brain tumor patients any more often than absolutely necessary. One technology which has come around in systemic cancer, but now also in glioma, is the fact that there are particles, extracellular particles, that can be sampled by phlebotomy, by circulating tumor DNA. Our own laboratories at the Hermelin Brain Tumor Center in Detroit have a publication in Press on a methylation assay, looking at, again, patients where we have matched plasma over time, primary tumor, and non-glioma controls. And this is in review. But it does portend the day where we can actually do serial sampling of a tumor genome by simply sampling circulating blood. This has been approved, in fact, for a number of point mutations for systemic cancer, but not so far with glioma. But these are certainly on the way, and I think will allow us to inform our models of response and engagement of clinical targets in a much more sophisticated way than the relatively infrequent opportunity we've had to sample tumors in the context of phase 0 clinical trials, for example. The other biologic observation that came on from the Cancer Genome Atlas, from our own place, has been the recognition that there are certain amplifications of genes that we know about. EGF receptor is one of them. There are several others. But it does turn out that the mechanism of how genes are amplified does turn out to be uniquely different. And in fact, many of the amplified genes are amplified in extrachromosomal DNA fragments. For the moment, these are actually not sampled by conventional next-gen sequencing techniques that we use in the laboratory today. And so these are not typically part of the reports of systemic genomic analyses. If you, however, look at the tumors that do have these, glioblastoma is head and shoulders above other cancers as having a characteristic factor that the amplification of many of these functional genes is extrachromosomal. Now, it's not entirely clear yet whether, in fact, the extrachromosomal amplification can be easily detected, or whether it portends response to targeting those. The point is that we're missing a lot of amplified DNA when we do simply genomic DNA from tumor material. And we need to look at other ways and other technologies to capture these extracellular amplified genes. It's another one of these sort of characteristic features of glioblastoma that distinguish it from many other cancer types. And this is the work of Ana Di Carvalho in the laboratory. She has actually looked at this in the context of a series of patient-derived xenografts. These are from a large number of the patients who actually are participants in the Cancer Genome Atlas, for which we have whole genome sequencing and all the other platforms. And she's recreated those tumors in animal models and looked at the ability of these patterns to be retained in the animal model, allowing us a tremendous laboratory model to evaluate targeted therapeutics in the setting of these gliomas. This is work where she was actually able to show this in a Nature Genetics paper to show this extracellular DNA amplification, which actually changes in pattern in vivo, in culture, and from the primary tumor. Not from our center, but there's been some other tremendous advances in genomic technology that have allowed us to have a tremendously improved insight into the biology of these tumors, and consider that a tumor is rather not a uniform entity. It's an organ of itself and has its own ecosystem. The tremendous information by single cell RNA-seq has allowed one to do evolutionary trees and the branching trees of evolutionary responses to selective pressure in single tumors, where you can actually look at tens of thousands of cells in a single tumor by barcoding them and looking over time how they evolve as a result of different selection pressures and how they respond to the intervention of blocking, let's say, a signaling cascade. What this will do, obviously, is to inform therapeutic tactics. And because the ecosystem of a tumor is very dynamic, there are multiple strategies that can be employed to, for example, block a resistance path by which a tumor would escape a single cellular blockade. There are several very, very good examples of how this tactic is being deployed in the animal model system. If this could be scaled to the point of liquid biopsy, where you could actually look at the emergence of a resistant clone, for example, by sampling by liquid biopsy, we will have the ability to be preemptive in our ability to block tumor progression. And several examples of this have actually been shown in lung cancer. And we hope to see the day where that technology can be scaled to detect the brain tumor ecosystem as well in circulating blood. Data capability, of course, in the big data era is also tremendously scalable. So while we have seen the Cancer Genome Atlas, which is in the hundreds to single-digit thousand cases, there have now been screening platforms that have integrated tens of thousands of cases. And there are now the ability to screen the sensitivity of patient-derived cells using robotics and other techniques, and readouts of toxicity in singles and combinations of therapy. And this is being done around the world. Many of these data sets are public and being shared. So the crowdsource of data science is truly international. The original Cancer Genome Atlas, I think, did kind of break new ground in the context of team science and open data. But it's been returned upon both by research and now on these improvements in technology with a similar motive to share these big data. One of the other targets that we've been able to come to recognize, in fact, is the immune background. Now, of course, many of the patient-derived xenografts and the implant models we've used historically were in immune-suppressed mice because these were human tumors in xenograft. And so what has happened now with the presence of humanized animal models, the ability to look at the other component of the tumor ecosystem in the immune cell populations is now coming on. And this is one example of the influence of the macrophage subtype population in response to radiation therapy that has now identified a therapeutic target that being CSF1 receptor, as being able to improve outcomes to response to radiation therapy in this preclinical model. This idea has already been translated into the clinic as an active clinical trial by Novartis. So these examples of the ability to become much more sophisticated in leveraging our understanding of tumor biology ex vivo has been tremendously advanced by our ability to take advantage of these humanized mice as hosts for primary tumors. So a lot of interesting biology, a lot of stamp collecting. What do we do about it? The FDA and Congress, as part of the 21st Century Cures, mandated that improvements in clinical trial methodology just must happen. There have been a number of tactics to improve the ability of clinical trials to be actionable and iterative and faster and smarter. And there are a number of technologies around that. The biggest of those are so-called platform trials. And there have been a number of those from breast cancer and other lung cancer types, and even in Alzheimer's disease. These adaptive trials, which use Bayesian logic, have now been deployed into really the current generation of the kind of state-of-the-art clinical trial, which has been called GBM Agile. Remember that there are many different therapeutic targets. And the question is, how do you manage these? How do you translate them to the clinic? And how do you look at combinations in a rapidly cycled way in order to improve outcomes? Because at the end of the day, of course, this is our mission. The biomarkers to define clinical subtypes or to define therapeutic targets are available. The question is, how do you deploy them into clinical trials in a rapid way and an iterative way to improve upon outcomes quickly by taking advantage of the multiple different data sets, by taking advantage of some of the preclinical and clinical research we talked about a little bit earlier, and the data science around this. How can we actually return this to the clinic? The data sets we're talking about are massive, and this requires obviously major team science, but this is ongoing. These platform trials will include medications from multiple pharma partners. The original trial to do this was in Boston by Brian Alexander, called the INSIGHT trial, where multiple arms could be competed against one another. The early outcomes were assessed and then redeployed into assigning randomization likelihoods based on near-term outcomes. I'm speeding up a little bit because I'm afraid I'm running short on time, but the point is that we have the ability to execute clinical trials with some of our biomarkers that we feel very strongly about, and to look at new arms on an ongoing basis, on an ongoing clinical trial engine, and this is called GBM Agile. Agile stands for the Adaptive Global Innovative Learning Environment. Glioblastoma was the first tumor type for which this methodology has been deployed in its sort of best iteration. And it's sponsored not by the NCI, not by pharma, but by a philanthropy coalition called GCAR, the Global Coalition for Adaptive Research. The idea is that you have multiple arms that compete against one another. Successful arms are promoted, ineffective arms are demoted and excluded, and the trial never stops. This trial was initiated in 2019, and Henry Ford Hospital was proud to put the first patient in November of 2019. This is an international clinical trial because it is critically dependent on the numbers of patients and the rapid accrual of patients to this trial to allow this machine learning engine to adapt and to reassign therapy based on early readout responses. This will be how multiple different treatment arms will be put head to head against one another in the most rapid way possible to accelerate outcomes. Rather than having individual clinical trials with drug A and B and C by individual cohorts and a nice paper coming out, this is the idea to consolidate and to wrap these together to then deploy this into the real world. There is now a range of tactics for clinical trials, which include the trials we know about, the phase 3 type randomized trials, but also the more pragmatic and real world trials. And the evidence coming from those in the real world are critically important as well. Again, a data-driven enterprise, worldwide team science. The idea is to iterate over and over, but quickly, and being as impatient as we must be with this huge treasure trove of data to improve how we do clinical trials, because we know why we do the clinical trials, because the outcomes are still never not enough. The future of precision medicine, just quickly, Digital health is mainstream. There are many data types in all domains of medicine now. They are informed, but the standardization and the data science around dealing with these massive data sets is critical. Machine learning and artificial intelligence are some of the tactics to make use of data. This will be deployed in imaging and in diagnostics and in drug design. The clinical trials are already being informed by some of these data strategies, as I mentioned, including these Bayesian trials using machine learning to assign randomization. Pharmacogenomics, et cetera, et cetera, et cetera. It's just all over the place. The precision medicine is the new theme, which is a data-driven enterprise for optimization of outcomes. And we need this badly in the context of glioblastoma, but it will be pervasive across the health system. And Dr. Inam, I'm going to stop there, and thanks very much, everyone, for their attention.
Thank you, Tom. That was just amazing, the way you put everything together in 20 minutes. It's just, only you can do that. Sorry, Dr. Shehzad is the chair of the session, so Dr. Shehzad or Imran is the moderator. Go ahead, please. You're mute, Dr. Shehzad.
Sorry. I was just going to add that as fantastic as this talk was, what is more exciting is Chen Zhongping from Korea is going to share his experience with precision medicine as well. So this builds up the perfect platform for that talk too. So we'll take questions in the end.
Dr. Batchelor is on the docket as well for later on. So this is an introduction, by no means a monopoly on the good ideas, but a good introduction, I hope.
Thank you. Thank you very much. And I'll hand on the mic to the moderator for the next speaker. Thank you.
All right, thank you. Next up, we have Dr. Vani Santosh, who will be talking about glioma classification updates from WHO 2016 and beyond. Dr. Vani is a professor of neuropathology at the National Institute of Mental Health and Neurosciences, India, and she has served as the president of the Indian Society of Neuro-Oncology.
Thank you. Can you hear me?
Yes, we can hear you.
Yeah. Thank you, Professor Arthur Inam, for giving me this opportunity to take part in this Neuro-Oncology Symposium. Certainly a great pleasure for me to be a part of the discussion. And after listening to that excellent, complicated lecture on data science in neuro-oncology on glioblastoma precision medicine, my lecture will be a little more basic, and in the next couple of minutes, I'll give you a few updates on glioma classification, what we know about them in WHO 2016 and beyond that as well. We know that the classification system that we follow for CNS tumors is the WHO classification, and the first 4 editions between 1979 to 2007, the classification was based solely on the histomorphology of the tumors. Post 2007, there has been an explosion of the molecular data from which have evolved a growing number of molecular biomarkers with important diagnostic and prognostic information. And several of these parameters have been incorporated into the revised 4th edition, that is the WHO 2016 classification that we are currently following, that features a combination of morphology and genetics and has brought about restructuring in the classification of several groups of brain tumors. However, we know that our knowledge on the molecular genetics of brain tumors is ever expanding, and in order to keep in pace with that, updates such as the C-Impact Now are being periodically published, and they serve as vehicles to connect the revised 4th edition with the upcoming 5th edition of the classification. So what I'm going to do today is to briefly discuss the existing and the evolving classification of diffuse gliomas that include the lower grade gliomas corresponding to WHO grade 2 and 3, that is the astro-oligo as well as the oligoastrocytomas, as well as glioblastoma WHO grade 4. Diffuse gliomas are a prototype example of a group of tumors where there has been a paradigm shift in classification from histopathological to molecularly defined entities. And the 3 clinically relevant molecular biomarkers, the 1p19q co-deletion, the IDH, and the ATRX mutations, have been used to generate a molecular diagnostic algorithm that is now found to be superior to the classical histopathological entities. And this is the algorithm put forth by WHO 2016 for the approach to the classification of diffuse glioma. You just saw this slide, nicely explained by Professor Mikkelsen. So as you can see, it has 3 tiers. The first is histology, where the tumor is a glioblastoma or a lower grade glioma of any of the phenotypes. Then the IDH status, where it is IDH mutant or wild type. And in the lower grade glioma, there is another tier that is 1p19q or other genetic parameters such as the ATRX, TP53 mutations. And using this algorithm, one can diagnose the specific histomolecular subgroup of diffuse glioma. And of course, there is the provision for the NOS or the not otherwise specified entity that implies that the necessary genetic testing is not performed or the results were inconclusive. So what are the technical platforms we use routinely for the evaluation of these diffuse glioma markers? It includes the simple immunohistochemistry for surrogate molecular markers such as IDH1R132H. This is the canonical IDH mutation. ATRX, where you look for loss of expression that corresponds to the mutational status. P53, the H3K27M, as well as the BRAF V600E. Fluorescent in situ hybridization is the technique that is used to assess the 1p19q co-deletion status. Targeted gene sequencing or Sanger sequencing is used for the assessment of the rare IDH1 and 2 mutations, the TERT promoter mutations, and methylation specific PCR is what we do for the assessment of MGMT promoter methylation. And you should know that all of them can be performed very easily on the formalin fixed and paraffin embedded sections itself. So these molecular parameters have been incorporated into the WHO 2016 classification, and this slide compares the 2016 with the 2007 classification. In 2007, the tumors were histologically defined, and therefore we had all astrocytic tumors clubbed together, including the circumscribed astrocytomas. Then came the diffuse astrocytomas, followed by oligos and the oligoastrocytomas. But now all diffuse gliomas come under one header, which is known as the diffuse astrocytic and oligodendroglial tumor, that encompasses all the molecular subgroups that we are now familiar with. And the circumscribed astrocytomas come under another header known as the other astrocytic tumors, because now we know that their molecular alterations are distinctly different from that of the diffuse gliomas. So as per the WHO 2016 classification, diagnosis of oligo or anaplastic oligodendroglioma mandatorily requires the demonstration of IDH mutation, 1p19q co-deletion, in the absence of which the tumors are designated as not otherwise specified. This is classic oligodendroglioma histology. By IHC, you can see that it is positive for IDH1R132H. It shows retained ATRX expression, P53 is negative, and by FISH, there is 1p19q co-deletion. And so the integrated diagnosis here is oligodendroglioma, IDH mutant, 1p19q co-deleted, WHO grade 2. Similarly, diffuse and anaplastic astrocytomas are either IDH mutant, which is more common, or the IDH wild type, that is uncommon. Of course, there is the NOS subgroup as well. This is anaplastic astrocytoma. You can see the anaplasia, the brisk mitosis over here. By IHC, it is IDH1R132H positive. Now you can see there is ATRX loss of expression and diffuse P53 immunopositivity. And the integrated diagnosis here is anaplastic astrocytoma, IDH mutant, WHO grade 3. And when we have this IHC profile, further 1p19q testing is not required for the astrocytic tumors, as recommended by the C-Impact Now guidelines, which I'll come to subsequently, as well as our own Indian Society of Neuro-Oncology consensus guidelines that we have put forth. However, if the tumor is an astrocytoma, it is negative for IDH1R132H by IHC, then sequencing will be required for the rare IDH mutations in order to determine whether the tumor is an IDH mutant or an IDH wild type tumor. And therefore, oligoastrocytomas and anaplastic oligoastrocytomas become an obsolete entity, because if molecular testing is performed, they're either molecularly defined astrocytomas or oligodendrogliomas and remain as a histological, not otherwise specified entities. So the most common mutations that we see in these diffuse glioma, as you already heard, is the IDH mutations. Seen in 100% of oligodendrogliomas, grade 2, grade 3, approximately 80% of grade 2, grade 3 astrocytomas, and about 8 to 10% of the glioblastomas. And we do know that it is associated with a favorable prognosis, as seen in several studies, particularly in combination with 1p19q co-deletion. And this is our previous study where we have shown the same findings. IDH wild type astrocytomas, they account for about 20% of all the lower grade astrocytomas. Now, what are these tumors? These are a set of lower grade astrocytomas which are aggressive. They look like grade 2, grade 3 on histology, but several behave like glioblastoma. For example, this is one of our cases, a 35-year-old male, where we diagnosed this to be an anaplastic astrocytoma on histology. And this was IDH wild type both on IHC as well as on sequencing. And the tumor progressed very rapidly to recur as glioblastoma within 5 months of the initial diagnosis. In fact, in an earlier study, Roos and colleagues from the German group have shown that the IDH wild type lower grade astrocytomas, they actually biologically resolve into the glioblastoma molecular subgroups itself. However, that concept is changing over a period of time, and recent studies have shown clinical heterogeneity in the behavior of even these IDH wild type lower grade astrocytomas. And now they have been molecularly stratified as molecularly GBM-like. These are the tumors that harbor GBM-like mutations such as EGFR amplification, gain of chromosome 7, loss of chromosome 10, or third promoter mutations. They're associated with a poor prognosis. Not molecularly GBM-like, they do not have these mutations. They're associated with a less aggressive course. And of course, there is the NOS subgroup when the testing is not performed. On the other hand, we know that IDH mutant astrocytomas are associated with a favorable prognosis. However, recent studies have identified a subset of rapidly progressing IDH mutant astrocytomas as well. So what are we seeing post 2016 classification? There is a lot of emerging molecular data that could actually affect the tumor, CNS tumor typing itself. To address this, the C-IMPACT Now, that is the consortium to inform molecular and practical approaches to CNS tumor taxonomy, was announced in the year 2017, sponsored by the International Society of Neuropathology. The goal of the consortium has been to facilitate the inputs and review novel diagnostically relevant data and to determine how much such information can be practically incorporated into the subsequent classifications. 7 updates have been published till date, but I will discuss only those that are relevant to my lecture. We were looking at the IDH wild type lower grade astrocytomas. The C-IMPACT Now update 3, it recommends the diagnostic criteria for these IDH wild type lower grade astrocytomas and states that only those tumors that harbor GBM-like mutations like the EGFR amplification, gain of chromosome 7, loss of chromosome 10, or third promoter mutations should be referred to as diffuse astrocytic glioma IDH wild type with molecular features of glioblastoma corresponding to WHO grade 4. And this is the only subset of the IDH wild type lower grade astrocytomas that are associated with an aggressive behavior, not all of the IDH wild type astrocytomas. On the other hand, now we know that there is a subset of IDH mutant astrocytomas that are rapidly progressive, and some molecular markers associated with rapid progression have been identified. This includes the CDKN2AB homozygous deletion, amplification of CDK4, PDGFRA, NMYC, as well as the low GSIMP levels. Of this, the most robust of the markers has been the CDKN2AB homozygous deletion, which can be detected by the FISH technique, and this has been validated in the prospective cohorts. What is CDKN2A? It is cyclin-dependent kinase inhibitor 2A gene that is located on chromosome 9p21.3 locus. It encodes for 2 tumor suppressor proteins, as we are well aware of, the P16 as well as the P14. And loss of CDKN2A has been shown to be associated with a shorter overall survival in IDH mutant lower grade gliomas, as seen in several of these studies. In fact, an IDH mutant astrocytoma, which is grade 2 or grade 3 on histology, but harbors the CDKN2AB deletion, it conforms to WHO grade 4 tumor itself. Now, these parameters have been incorporated by the C-IMPACT Now update 5, which recommends grading criteria and terminology for IDH mutant astrocytomas, which is as follows. IDH mutant astrocytoma is now graded as grade 2, grade 3, and grade 4. Note that the terms diffuse astrocytoma, anaplastic astrocytoma, and IDH mutant glioblastoma have been removed. And the Roman numerals for the grading is replaced by Arabic numerals. The reason is that the terminology is the same in all the 3 grades, and Roman numerals can result in some amount of transcriptional errors. So IDH mutant astrocytoma grade 2 are well differentiated astrocytic tumors with no or mild anaplasia, with nil or low mitosis, without microvascular proliferation or necrosis, and no evidence of CDKN2AB deletion. IDH mutant astrocytoma grade 3 are tumors that exhibit anaplasia, significant mitosis. Note that there is no cutoff that has been mentioned, no microvascular proliferation necrosis, and no evidence of CDKN2AB deletion. And IDH mutant astrocytoma grade 4, what we are currently referring to as IDH mutant glioblastoma, are tumors that show microvascular proliferation necrosis, or they needn't show this. They can just harbor the CDK and 2AB homozygous deletion or a combination of these features. And this highlights the importance of the molecular alteration in IDH mutant astrocytomas. You've seen this slide in the previous talk. This is how WHO 2016 segregates the glioblastoma into IDH wild type and the mutant. And we know that the wild type tumors correspond to the primary glioblastomas. They account for more than 90% of the cases seen in older individuals associated with a poor prognosis. And the mutant glioblastomas account for only 10% of all the cases and seen in younger individuals with a better prognosis. And whilst the mutant astrocyte glioblastomas are known to be preferentially located in the frontal lobes, the wild type tumors can be anywhere in the supratentorial compartment, and their molecular alterations underlying these two groups are distinctly different. However, the C Impact Now Update 5, as per its recommendation, the term IDH mutant glioblastoma is now replaced by IDH mutant astrocytoma grade 4 to enforce their association with the continuum of the rest of the IDH mutant astrocytomas and differentiate them from the classical glioblastoma, that is IDH wild type. So when we are looking at now referring to glioblastoma in the adults, we are only referring to IDH wild type, but there is no more IDH mutant glioblastoma. And the very recent C Impact Now Update 6 suggests a diagnostic criteria for these IDH wild type glioblastoma. So glioblastoma IDH wild type is now defined as an IDH wild type diffuse astrocytic glioma with any of these features: microvascular proliferation or necrosis on histology, or one or more of the following molecular features of glioblastoma, such as the TERT promoter mutation, EGFR amplification, gain of chromosome 7, loss of chromosome 10 copy numbers. If you look at glioblastoma in the young adults as well as in the pediatric age group, the heralding underlying molecular alteration, as you know, is the histone H3 mutations. And the entity that has been included in 2016 classification is diffuse midline glioma H3K27M mutant. And the C Impact Now Update 2 provides diagnostic clarification for this tumor. Diffuse midline gliomas are now defined as diffuse, that is, they're infiltrative tumors, not circumscribed. Glioma usually astrocytic morphology, but it can have an oligomorphology. They occur in the midline that is defined by the thalamus, the brainstem, as well as the spinal cord, and harbor the H3K27M mutations that can be detected by IHC for the protein expression. And this corresponds to WHO grade 4 and should not be used for any other tumor that is H3K27M immunopositive. For example, a subset of posterior fossa ependymoma, pilocytic astrocytomas, as well as the gangliogliomas. H3G34R&B mutant high-grade gliomas is an emerging entity. This tumor is known to occur exclusive to the cerebral hemispheres in the adolescent and the young adults. Histologically, they're either GBM-like or they can have this primitive neuronal features, and very characteristically on IHC, almost 100% will show ATRX loss of expression, a diffuse P53 immunoreactivity. This gives a clue for this G34R&B mutant high-grade gliomas. MGMT promoter methylation is seen in about 65% of the cases. They're associated with an intermediate prognosis and will be included in the next classification. And this is one of our cases of G34R mutant cerebral hemispheric glioblastoma. You can see that it has very undifferentiated cells. It shows loss of ATRX expression and a diffuse P53 immunopositivity. And we also know that epithelioid glioblastoma is now a variant which is described in the young adults and the children. This is the classical histology, and more than 50% harbor the BRAF V600E mutations, which can be detected very nicely by immunohistochemistry itself. So what's next with all these new molecular information and the recommendations that have come in from the C Impact Now updates? All of them will be incorporated into the next classification. That is the 5th edition of the WHO classification of CNS tumors, slated to be released late in 2020 or early 2021. And finally, this table just gives you a glimpse of how diffuse glioma classification is going to evolve towards the 5th edition. We will have two major groups: diffuse adult type glioma, genetically defined. This will include astrocytoma IDH mutant, which is grade 2, grade 3, and grade 4. Oligodendroglioma, IDH mutant, 1p19q co-deleted, which will be grade 2 and grade 3, and glioblastoma, which is only IDH wild type. The second major group will be the diffuse high-grade pediatric type glioma defined by the histone H3 status, which will include the diffuse midline glioma H3K27M mutant, the hemispheric glioma, that is G34R and B mutant, and of course there is the wild type group as well. So with that, I thank you for your kind attention, and I can take any questions. Thank you.
Great, thank you. Thank you, Dr. Santosh.
Yes, thank you, Dr. Vani Santosh. As I mentioned earlier, we'll take the questions in the end, but this was really, really informative. I was really interested in hearing you talk about what to expect in the 5th edition. So over to our moderators.
All right, thank you. Next up, we have Dr. Rakesh Chalali, who will be talking to us about molecular markers in clinical practice for common brain tumors. Dr. Rakesh Chalali is a professor of radiation oncology and senior neuro-oncologist, as well as the medical director at Apollo Proton Cancer Center, Chennai, India. Dr. Jalali is also a member of the Senior Advisory Council of the Indian Society of Neuro-Oncology, as well as founder of Brain Tumor Foundation, India.
All right.
Rakesh,
Yes.
just leave this slide for a minute on it, you know.
Okay.
I just want to absorb it. You know, Pakistan, India, we have it together on one slide. I just want to, you know, make a poster out of it, honestly.
Sure.
This is,
Sure.
this is beautiful. Okay, sorry, go ahead.
Thank you. So again, a great pleasure and honor to be participating in this wonderful symposium, which we have all enjoyed for the last 2 days, and this is the final day today. And you already heard 2 outstanding talks on the evolution of the various pathological, but more importantly, the molecular markers, how they have changed the landscapes of neuro-oncology practice. Now we go to the really, you know, the beast of the neuro-oncology, the glioblastoma. As was mentioned last night, in spite of so many things, that still it's a formidable challenge. We have gained some insights, we have made some progress, but glioblastoma still, you know, the 2-year survival is hovering about 26-27%. That's about 9 to 10% of them can expect 5-year survival. And we were lucky to introduce temozolomide in 2001 in India, and over a period of time, our data more or less corroborates what is expected in different parts of the world. And that brings me to one case, and this is a reflection of the case that was discussed in the tumor board yesterday as well. 47-year-old lady who presented with a seizure in 2009. Histopathology was glioblastoma. MGMT promoter was methylated. Received the standard radiation plus adjuvant temozolomide, was kept under observation serial imaging, and did quite remarkably well for several years. In 2016, however, the tumor did eventually progress, was reoperated upon, and now we have a histology of glioblastoma. We always ask the pathologist how much is the treatment-related change, and can you quantify the 3 components, whether it is a recurrent tumor, whether it is a treatment-related change, or is it just the residual component of the glial pathology in general? It was obviously an MGMT promoter methylation. They don't really change. But what was interesting was ATRX was lost, and that signifies the astrostic lineage, and IDH1 was positive, which we had not done in 2009 because it was not available. But in 2017, we did IDH positive, and we just heard about 10 to 15% of the GBMs will have IDH mutation positive. And then, you know, therefore, this patient might have done better than what is usually expected of a glioblastoma, and was a relatively longish survival. Now, Dr. Vani just tells us the rapid pace with which the molecular information is being translated into practice, that we will not be able to call it now glioblastoma as per the C impact now, which is going to be translated into presumably the WHO next 5th edition. We will actually call it now IDH astrocytoma grade 4. And these are the things the clinicians, you know, like yourself, ourselves, we have to learn as to how to keep up the pace with the rapid change of the molecular landscape in our practice. Now, you already also heard the impact of IDH and Dr. Mickelson's in his outstanding talk, and as well as one is they demonstrated to us the importance of two fundamental markers, the IDH as well as the 1p19q co-deletion, and it was partly based on the TCGA data, a cohort of Japanese data, and it was clear that the patients who harbored both the IDH mutation and 1p19q co-deletion, obviously the oligodendroglial component and dendroglial tumors, they did exceedingly well, while the patients who had only IDH mutation did not have 1p19q, ATRX was lost and obviously were astostic grade 2 and grade 3. We call them lower grade gliomas or intermediate gliomas. But was disconcertingly, if the patient had an IDH wild type, they did not do well at all, and they were almost akin to primary glioblastomas. And therefore, they had an aggressive behavior, and that caught the attention of many people throughout the world. We also have realized, and Professor Dufau, who was the speaker on the first day, also showed us that IDH can be used by neurosurgical oncology community. Sometimes it can also show us the relative increase or relative progress or growth of the tumor in a low-grade glioma who you are observing. Looking at the volumetric diametric expansion, it has been seen that the ones who have IDH mutation are show relatively slower growth as compared to IDH wild type, and that has impacted both the barren-free survival as well as their overall survival. So that has obviously been also been incorporated in our clinical practice as to how we manage these patients. Now, observation in low-grade gliomas, they always have been a kind of a challenge, whether you should observe, whether you should operate, whether you should give radiation. Nowadays, we give chemotherapy along with as well. More or less, the clinical factors of younger age, less than 40, minimal residual disease or no residual disease, but more importantly, also it's the molecular profile, especially if they are IDH mutant. If they have 1p19q co-deletion, obviously there will be oligodendroglial lineage. And nowadays we use the third mutation in India. In some centers, we use routinely the third mutation as well now. So if they have what is called triple positive to some extent, taking the clue from breast cancer, for example. So they have IDH mutation, they have 1p19q co-deletion, third mutation signifies the most favorable, and obviously the histological genotype being the oligodendroglial, you could possibly observe them quite well. But if they don't have these clinical factors or favorable factors, or they do not have favorable molecular profile, then obviously it is a little bit more difficult to observe them, and perhaps an upfront adjuvant strategy would be more appropriate. Obviously, all these factors, yesterday's tumor board was a classic demonstration how critical it is to have everything together, looking at the scans, looking at the pathology, but increasingly what is emerging as a molecular neuro-oncology tumor board, so as we know all this information to take care of our patients appropriately. What was also has been demonstrated by the RTOG 9802 study started in 1998, and that time temozolomide was not there so much into the picture, so it was an RT plus PCB regimen, which was the classic standard regimen compared with radiation, especially in those patients who were what is called aggressive high risk low grade gliomas incorporating more than 40 years of age or significant residual disease. And you could see the tremendous amount of impact of outcome. My medical oncology, neuro-oncology colleagues will tell there is hardly any solid tumor which has shown a 20% improvement in 10-year survival by the addition of just one chemotherapy agent in a tumor which we hitherto traditionally thought to be not so chemosensitive. And that was quite a remarkable impact of the addition of chemotherapy. Now, many parts of the world actually incorporate temozolomide in place of PCV because of the ease, because of the more favorable toxicity profile, and perhaps more experience also. But what was also was quite interesting to see, this maximum impact took place in those patients who again harbored our favorite gene, the IDH1 mutation. And that has also impacted the other cooperative studies to some extent. The Catalan was the European study looking at the primary anaplastic astrocytoma, which were 1p19q non-co-deleted, therefore obviously an astrocytoma, not the oligodendroglioma. And they had originally a 2x2 factorial design, and they wanted to see the impact of the addition of temozolomide either in concurrent or adjuvant setting, or combination of concurrent and adjuvant a la Stoops protocol. But after the advent of RTLG 9802, I think RT alone is not no longer. They are basically looking at the concurrent versus adjuvant strategy. The CODEL study of, obviously looks at the co-deleted oligodendroglial tumors, and therefore, again, you have to add chemotherapy in both, not radiation alone, not chemotherapy alone. And there, they are looking at whether it's PCB versus temozolomide, which one is superior in terms of outcome, both in terms of survival, but also in terms of toxicity and quality of life. And we all have, for many years, we have known right from the retained process data and many others data that, and very large cooperative study, both in North America and Europe, how the impact of 1p19 co-deleted anaplastic oligos have been made. And anaplastic oligos, being a grade 3 tumor, still can have an excellent survival more than 15 years now, in spite of the grade 3 tumors. So the European group and the North American group combined together this data information and was published last year, looking at the IDH and 1p19 co-deleted status. You already heard the CDKNA2A and 2B, the impact of that, and also into the C impact now, as well as the new classification. And that is another thing that we have to learn now how to incorporate in our practice, but essentially try to look at that what are the classic features of astrocytoma and what are the classic features of oligodendroglioma, both on the histomorphology, molecularly, the definition of these markers, and also the impact of adjuvant therapies in these kind of patients. So bearing these in mind, we were very conscious that in a rapidly changing scenario in the world about the molecular information, the Indian Society of Neuro-Oncology, I think 5 years ago now, we decided that we must do something about it. And so therefore, Vani and I, we got with like-minded people together, and we had been carrying out these guidelines. We had already published the medulloblastoma guidelines, and therefore in 2017-18, we, in a very pragmatic way, what is very relevant given the diversity and given the landscape that we have in our own parts of the world, we subsequently also went on to develop guidelines for lymphoma and germ cell tumors. But essentially, this was the document, and we consciously published in Neurology India, which is the most widely read journal in the country, and is also open access, free downloadable by any part in any part of the world, is indexed on the PubMed. So this is a relatively exhaustive document looking at various aspects, and there are several supplementary files looking at breaking down not only just the consensus guidelines, but also how to do these testing. What are the platforms that you have to do? What are the industry? What are the companies that you should go to? What is the cost of these therapies? And using the molecular markers, and also the clinical relevance of these. So this was a useful effort, I think, by the ISNO, and this has been quite widely circulated and quite widely adapted, and I have seen in many parts of the country and some parts of the world, in fact, as well. SNOSA, a case in point yesterday, as we discussed, have tried to incorporate some of these guidelines. That brings me to the case number 2, which was a 31-year-old gentleman. As you can see, it's rather midline tumor in the left thalamus, non-enhancing. And we actually thought it could be initially like a low-grade tumor. There was some obstructive hydrocephalus, as you can see. We even thought of a pilostic astrocytoma, although it was non-enhancing, or we could think of a high-grade glioma. So how to proceed? It's always difficult to excise these relatively deep-seated tumors, so whether only a biopsy should be done. Occasionally, we also get requests, can you irradiate them upfront without a histological proof? That is no longer, most of the times, we don't do it anymore. But nevertheless, this is not an infrequent case scenario that we get into. So finally, a biopsy was performed in some other center. This is the case. I was still in Tata Memorial Hospital in Mumbai. There was this report that you are typically seeing in your practice, low-grade astrocytoma, NOS, and we didn't know what to do it. So which molecular marker to do? If it was a pilostic, then maybe we should do a BRAF fusion. We always have to see the IDH status, especially if it is from the medial temporal lobe. Sometimes they can go towards the thalamus. Or should we do histone study, or should we do TERT mutation? We did the BRAF study initially. Both the BRAF fusion as well as BRAF mutation came negative, practically ruling out a pilostic astrocytoma. And then we did the IDH. IDH was wild type, both in the IHC as well as the sequencing. What we also have to remember, if clinical radiologically, it does look like an IDH mutant tumor, but the IHC is negative, in about 10 to 15% of the cases, there may be another mutation, not the common 132, where the arginine is replaced by histidine codon, where you have to do so therefore you have to do a small RT-PCR Sanger sequencing, and which we many times commonly do in many places in the country. So unfortunately, this patient, we did the diffuse, the histone marker, the H3K27K mutant, although the WHO was not there at that time saying that, the new classification was not there. But if you have an H3K27 mutant, which is otherwise sometimes looking like a low-grade glioma, you upgrade the tumor to grade 4 or glioblastoma. And then what was the management? We just gave radiation plus temozolomide. We still didn't know what to do, 6 cycles of temozolomide, but we were actually thinking he may do actually better than what we were still thinking whether histone will do something. But unfortunately, it was a classic. Within 8 months, he had a massive disease progression. We gave him some Avastin, some palliative care. Eventually, he passed away. And therefore, although it was a relatively adult population, we know that diffuse pontine glioma, vast majority can harbor the histone mutation. The H3K27M is the commonest, but in other sites, interspecific, Dr. Vani has already showed there are other mutations as well. And therefore, there is a case in DIPG, or now we call diffuse midline gliomas, whether there's a case to take a biopsy as safe as possible because there are some medication available. So one of the medication which we are very excited, and some of my patients are already on it, is a molecule which has been discovered on, which is called ONC201 molecule, and it has been in clinical investigation. You can see a classic brainstem glioma of this young patient showing a dramatic response, both radiologically and as well as clinically. And this has been captured in a small series so far in ONC201, and there are several ONC20 other studies, and we are waiting with abated breath, literally, because these are traditionally the most difficult tumors, but gives an example that how the molecular information has translated and transformed our targeted therapy scenarios such that we can have a therapy against it, and some of those difficult tumors can perhaps get better outcomes. Now, we were fortunate to have a relatively large number of patients on pleomorphic xanthocystosarcoma, which we published a couple of years ago, and also showed the importance of surgery, anaplastic PXA. But as was mentioned, a vast majority of them have BRAF V600E mutation. They do not have fusion, which is mutually exclusive, but they have V600E mutation. And as is also the case with epithelioid glioblastoma, which is a form of glioblastoma now incorporated in the new classification, and also some of the gangliogliomas. So therefore, we are very excited, and it was discussed with Dr. Noreen yesterday, the targeted therapies using both the V600 BRAF inhibitors, but also the MEK inhibitors. And there are several clinical trials looking at it, looking at dafrabenib and trametinib in these, and Novartis is doing these studies, and we are again excitedly waiting for these things. My final case is a 34-year-old lady who was actually thought to have a kind of a cyst, and she was traveling abroad that time, which was operated upon in Europe. But unfortunately, the histological surprise of anaplastic astrocytoma, IDH mutation, she came back to India. What was intriguing, and this is not uncommon in our clinical practice, they do have the oligo-looking cells, but 1p19q came non-codelated. So therefore, you cannot call it oligodendroglioma. It has to be anaplastic astrocytoma. What was also intriguing that ATRX is retained. Now, ATRX should not be retained in these cases, either that is seen in oligos or in GBM, and it really didn't look like GBM. So what we did was, there was a fair amount of residual disease present. We subjected this patient to a re-excision of the gross tumor, which was left behind, was also important from her prognosis and from curative intent. And we got more tissue. Now we had IDH mutation, and 1p19q both came delated. So there was a tremendous change in the prognosis from an anaplastic astrocytoma with a median survival of about 3.5 years, and now with an anaplastic oligodendroglioma with a median survival of more than 15 years. And that brings me to the final couple of slides that this was mentioned yesterday, that the epidemiology, the outcomes, the case scenarios, Dr. Inam, you yourself mentioned in the global oncology perspective, how we should collect our data, and we should not just extrapolate whatever is there in the West. For example, many years ago, we found out that our presentation of the age could be slightly different, and this has been captured by a review last year by some of the colleagues, international colleagues that we participated in. We also have a strong neurosurgery facility in general, there is uninhibited access to cadaver specimens. There is high-end instrumentation, even the operation theater, even we have 5 or 6 intraoperative MRIs. But you look at the number of neurosurgeons with respect to country, I don't have the Pakistan data, but I'm sure you have. And therefore, these are the challenges that we face. And also the radiation facilities, the neuro-oncology setups, the medical oncology, and so on and so forth. Our patient profile is also quite diverse. And this was a study we did many years ago, looking at the quality of life of patients in a routine neuro-oncology practice. We have the social stigmas, family hierarchy, protecting, abandonment, empowerment, diverse population, social, cultural factors, and that is why we do these things that we do, like the PISNO, the PASNO. I have to put my ring into the ring about my association with Henry Ford. Everyone is talking about Henry Ford. I was very fortunate and delighted to work with Tobias Walbert from Henry Ford, where we came together a few years ago looking at the palliative care scenario in neuro-oncology. And Tobias is doing phenomenal work in palliative care at Henry Ford in Michigan. And we found out what was amazing was there was several differences in the Asian context as compared to the Western. But the patient referral to palliative care, irrespective of the geographical state, was still abysmally low. Only 8% at the time of diagnosis, 11% only time at the recurrence, where a vast majority of these GBMs should be given to the palliative care and hospice cares right at the beginning. To some extent, the Brain Tumor Foundation of India, which I was very fortunate to be kind of involved in charge for 20 years odd, but we took a program about 10 years ago that any patient in the country who needed any molecular marker of IDH mutation, medulloblastomas, the ATRX, the 1p19q, even the histone, they will send the tissue block and we will fund them. And also we did some few other things. And now you have the Brain Tumor Foundation of Pakistan, and that could be one of the things perhaps you would like to conclude. So in conclusion, the markers available in India are now fairly well distributed throughout the country. And our focus is not only in the tertiary centers. My dream is that it should be like an ERPR of a breast cancer. Every single lab should do IDH mutation, ATRX, in some centers, MGMT, 1p19q, and in very specialized centers, BRAF, TERT, and many other things. And the cost is actually not so much. The IDH sequence, just the IHC, just $60. The FISH is a little bit expensive to some extent, but we did in the guidelines, if you have a classic morphology, IDH mutation, ATRX retained, you don't need FISH, 1p19q, that is an oligo. On the other hand, if ATRX is lost, then it's a clear-cut astrocytoma. So with some discussion with your pathology colleagues and molecular colleagues, you can actually do remarkable success. And again, I hope Dr. Anam again will like this slide, because I thought we belong to the same part of the world. Our dream, our challenge, our vision should be identical. And it's my, again, delight and pleasure to participate in this wonderful experience that we had for the last 3 days. Thank you very much.
Thank you, Rakesh. That was beautiful. Dr. Shehzad.
Thank you, Dr. Rakesh. Thank you, Dr. Rakesh. This was fantastic. And as I mentioned earlier, it's beautiful how the speakers' talks relate to each other and following the same theme. I think it was a good idea not to invite surgeons in this session, Dr.
Well, you are a surgeon. You're a surgeon, Shehzad.
So Imran, please invite.
Dr. Kim is a surgeon too.
Yes,
Okay.
but the smart kind who doesn't need to operate.
Yeah, these are smart surgeons. Okay, all right.
Imran, can we invite our next speaker, please?
Yeah, sure. So next up, we have Dr. Brian Day. He'll be talking about EphA3, a functional targetable receptor for the treatment of brain cancer. Dr. Brian Day is currently the group leader at Sid Faithful Brain Cancer Laboratory. He also serves as the director at the Children's Hospital Foundation and as the professor adjunct at the School of Biomedical Sciences.
And he's from Australia, so we missed that major. So it's like shift.
It's okay.
Where he is.
Can you hear me well?
Yes, yes, Brian. What time is it over there?
It's 2 in the afternoon.
Oh, so that's not bad. Okay, that's pretty good. All right.
Fine, it's fine.
Thank
So
you for
can you see
joining.
can you all see my screen now?
Yes, definitely.
Well, great. So thank you to the organisers for the chance to speak with you today. I thought, you know, we come from sunny Queensland in Brisbane, Australia, so I thought I'd put up a nice picture of what we have on our back doorstep, so the Great Barrier Reef. And when COVID is all over and finished, hopefully it'd be really great to have you come to Australia at some time and see us. So today I wanted to talk to you, I guess, a little bit of a change in gear from the other talks. I guess really focusing on more just sort of a single gene that I've progressed over a number of years to clinical trial. So this is my group in Brisbane, and no Pakistanis in my lab, but I do have a couple of very talented young Indian girls, Rochelle and Mansi. She's going back off to do sort of a neurosurgical program now, and Rochelle, a very confident proteomic scientist who trained in Germany. So the focus of the lab really is on both adult and pediatric brain cancer, and we really try and stay as translationally focused as we can. So there's been big things happening in Australia, I guess, in the brain cancer space that's worth mentioning. So the Australian Brain Cancer Mission has recently injected about $100 million into both basic research for brain cancer and also for clinical trials. So this is really great. I guess it's, as we all know, it's a very much understudied disease. And, you know, at least in Australia now, and I think in the US, brain cancer is finally starting to receive the attention it deserves. So as part of this mission, there's been the development of a Children's Brain Cancer Centre in collaboration with the Children's Hospital Foundation in Brisbane. I'm part of this directorship, but really it's a multifaceted centre really looking at survivorship, clinical trials, right through to translational science. So the centre's goal really is to improve every aspect of brain cancer that matters to children and their families. The other thing I wanted to touch briefly on really was we've spent a lot of time in my group developing a tumour bank, and we really wanted to make a bank, I guess, that was very well annotated. We tried to think for the future and really cryopreserve fresh tissue and you know, all the elements that we thought we might need in the future. And one of the good things, I guess, that we developed out of that was a resource that we're calling QCell. So I wanted to, I guess, give a little plug for this today. So it's a fairly small resource of primary glioblastoma models, only 12, but they have been incredibly well characterized. There's all the sequencing, RNA sequencing, proteomics, all the patient information, you know, drug response, all those things are freely available online. They've been used in over 40 publications, including Cancer Cell, Nature Neuroscience, Acta Neuropathologica. So they're incredibly well characterized small panel, and I'm happy to make them freely available for anyone for academic use. So please, if anyone needs good quality primary glioblastoma models, please contact me. I'm happy to facilitate. And then I thought, before I get into the main part of my talk, I would just talk very briefly about these glioblastoma organoids, which we've sort of recently adopted. So a paper by Jacob et al. Was published in Cell Reports, where they essentially take glioblastoma tissue directly from the theatre, and kind of like a tissue explant, you essentially manually chop it up and then culture it in spinner bottles, and you're able to grow out these little organoids. And I think the really exciting thing about this technology is that it really maintains the blood vessels and all the immune infiltrate and stroma for a short period of time. And I think it overcomes some of the problems that we've had in the past from in vitro assays. So here's a little bit of data that we've recently generated looking at H&E samples of these GBOs. And you can see here that really very nice, I guess, in situ type histology of the brain cancer. And if you match it to the original tumour from which it came, it looks very encouraging indeed. So I think I would just encourage people. It's a fairly simple approach, and I think it's a great platform for all manner of things, but especially for assessing drug response. So I guess that brings me to the main part of my talk, which will be focused on EPH receptors. So EPH receptors are the largest family of receptor tyrosine kinases. They're broken into two groups, either FA or FB receptors, so named for their binding to either ephrin A or ephrin B ligands. They come together and form classic dimers and tetramers in the cell membrane, and this initiates bidirectional signaling. So one of the, I guess, complicating and interesting phenomenons of this family is we get not only forward signaling through the kinase, but reverse signaling through the ligand. So as some of you will be aware, F receptors are widely implicated during embryogenesis, where they mediate cell adhesion, tissue boundary formation. And then we've known now for a number of years, over 20 years, that these F receptors are re-expressed in cancer and contribute functionally to tumorigenesis. So one of the family members that I've focused on over a number of years has been this EPHA3. So we know that this family member is expressed in the developing brain. We know it has a functional role in the developing heart, where it induces EMT leading to heart valve and septal formation. And this is part of the reason we were interested in this particular receptor initially, is we know that it's very lowly expressed in normal adult brain. So it makes it a really attractive cancer target. We previously knew it was overexpressed in sarcomas, renal cancer, melanomas, leukemias. So sort of a throwback, I guess, to what it does during embryogenesis, where it affects proliferation, migration, and fate determination. So this is just some old data to set the scene. So when we originally looked at expression, we found, this is in some 80 glioblastoma patient tissue samples, we found that it was significantly elevated in many cases, about sort of 60% of cases above normal brain. Also, using the Rembrandt database, we were able to correlate FA3 expression with patient outcome. So if your glioblastoma tumour expresses high levels of FA3, then you do significantly worse, much worse in fact. If your tumour expresses low FA3, then you tended to do better. So this was really, I guess, a strong signal that FA3 was acting as an oncogene in this setting. So I won't show all the data because it's published, and that was really just an introduction. But as I said, we found that FA3 was negatively correlated with survival. Also, it was on this most aggressive mesenchymal subtype, and it appeared to be on the more stem cell-like population. If we knocked the gene down, what we found was that the cells differentiated in vitro. That led to delayed tumour progression in vivo and a significant increase in survival. And also, as part of that study, we were able to show that we could effectively target it with a specific antibody. So then we wanted to translate this finding, and it's sort of been a long road, but we're in a fortuitous situation where we could leverage some work from my previous colleagues, Andrew Boyd, Andrew Scott, and the late Martin Lackman, who had worked with a US-based company called Humanigen to develop this drug recently named afabituzumab, which is an anti-FA3 drug where they'd taken it now, they'd humaneered it and got it to sort of phase 1, phase 2 in leukemic patients. So it really enabled this great platform, I guess, that we could springboard off our findings in brain cancer. And then we teamed up with Cure Brain Cancer Foundation, which is one of the leading foundations in Australia, who do a great job of raising funds. It's always a major obstacle when you're trying to get these small trials off the ground. So they contributed a nice starting pot of money, and we were able to get a trial going in both Melbourne and Brisbane. And this has really been led by Hui Gan and Andrew Scott in Melbourne and Paul Thomas in Brisbane. So it's a sort of standard phase 1, I guess. We're doing a dose escalation, but the sort of novel and exciting part of the trial was that we have an imaging component as well. And the idea here really is we wanted to assess brain penetration. So the antibody was labeled to zirconium-89. So essentially, and then given a fairly low trace label infusion dose, followed by PET imaging. And these are some of the results. So here you can see this is a patient with recurrent glioblastoma. You can see very clear tumour boundaries here with the FDG PET MRI. And then here, this is our data showing the afabituzumab anti-FA3 drug labeled to zirconium-89. And look, we were very encouraged by this because we saw very rapid and specific accumulation in the tumour. So this was in recurrent glioblastoma, but it certainly appears from our patient data now, we've done several patients that it seems to be penetrating the tumour very effectively. So what next? Well, as we all know, the sad story, we haven't really done that great a job of progressing new therapies. So we really need to push some new effective therapies through. There was a hint, so we know from the literature that there tends to be more mesenchymal type tissue in recurrent disease. And also from a small cohort of tissue I had, there was a sense that it might be going up in recurrent disease. And also based off previous trials with EGFR, we thought, well, perhaps antibody drug conjugate therapy could be good. And also now with the sort of pivot towards more pediatric brain cancer, we wanted to see whether FA3 could be functionally expressed there. So Kazi et al. From Sheila Singh's lab showed really nicely what we thought and couldn't actually prove in my group was that FA3 appeared to be going up in recurrence. So here you can see, this is for FA2 and FA3, particularly in the primary disease, which is light grey, it's elevated, but then in the dark grey recurrent, you can see there's a very, very significant increase in this FA3 protein. And also nicely, they showed that following chemoradiation treatment, this FA3 protein was going up. So this was all sort of putting the pieces of the puzzle together where we know we've got a tumour-specific target, we now have a targeting modality, and we know it's enriched in recurrent disease. So this is some of our work on ADCs, which you'll all be aware, it's an old technology. Carolyn in my group has really been working this up. And I guess the chemistry we've gone with for preclinical validation has been a non-cleavable lysine attachment to maytansine, and this has been conducted with Chris Thorect at the University of Queensland. But here, what I really wanted to illustrate was if you give this therapy and just keep the cells cold to induce stasis, what you see is that you'll really hit your target, your FA3 in the cell membrane. But when you warm it up to room temperature, what we see is we get activation of this receptor and internalization of receptor complexes. And that's what we want, is we're pulling that drug directly into the cell. So here's a little bit of data showing specificity. So we've taken 2 glioblastoma models, one FA3 positive, one FA3 negative. And what we see is if we hit this FA3 positive model, we get a very nice dose response of the antibody drug conjugate. But if we give it in the FA3 negative line, we see really no response at all. And in an FA3 positive line, we get a very clear apoptotic response, as shown here by cleaved caspase 3 peaking at 48 and 72 hours. And does it work in animals? Well, yes, it works nicely. So here we've done a PBS control versus the naked antibody versus the maytansine conjugate. And we've actually let quite large tumors form in these animals. And then we've started 2 treatments per week. And you can see here that really by 6 treatments, we're getting very clear tumor regression in these animals where the controls are being culled of disease burden. And ultimately, these tumours do recur, but we're able to very significantly delay survival. So we almost doubled survival in these aggressive models, which is almost the best we can do in our hands. We also teamed up with Faraz Alajay at QIMR, who has experience in radioimmunotherapy, and we're able to show similarly that if we take preformed tumours in animals, and in this case, it's the antibody conjugated to lutetium. We gave a single dose and got a very nice regression in tumour, leading to a significant increase in survival. And probably the thing that we've been most excited about has been the fact that we really see no toxicity at all, either with the antibody drug conjugate or radioimmunotherapy approaches. And we really attribute that to the fact that there's very low level FA3 in normal brain. So what about pediatric brain cancer? Or could it be functioning there as well? So here, if people are unaware of this, I'd encourage you to look at it. It's a really nice platform called BrainSpan, and you can look at your gene of interest and its expression from in the womb. So this is 8 weeks post-conception right out to adulthood at 37 years. And red bars indicate overexpression, blue indicate underexpression. And what you can see here really nicely is that FA3, as we would expect, is very high and functional in the womb, in the developing brain. then really at birth here at 37 weeks post-conception, you can see that FA3 is really turned off and is maintained at very low levels, or it's really not there at all in adulthood and also in early childhood. So I think this was very encouraging that not only in adults, but also in children, FA3 could be an encouraging tumour target. So here's a little bit of data from the MAGIC consortium, where we now first wanted to have a look in medulloblastoma samples. And what we're able to show was that FA3 appears extremely high in the Wnt subgroup of medulloblastoma. It's also elevated in sonic hedgehog, but doesn't reach significance, but also significantly elevated in group 3 and group 4 tumours. Really, this is just a similar extension of the same data, where now we're looking at 763 medulloblastoma samples. You can see incredibly high expression in the Wnt, but also very, very high expression in the sonic hedgehog group 3 and group 4. We were also able to use some single-cell RNA sequencing data from this recent NEFTEL paper in Cell late last year, so to also assess expression in DIPG. So DIPG is this very aggressive midline glioma in young children. It's incurable, it's rare, but highly incurable. And also we see the same response here, where it appears FA3 is very high in an equivalent proportion of adult glioblastoma patients. So we've started to have a little look at expression by immunohistochemistry, and once again we can detect FA3 here coming up in medulloblastoma tissue samples, and with sort of a pattern of staining that we would expect. And also we're now moving to in vitro validation of our ADC targeting as well. So like in adult glioblastoma, we're seeing a nice dose response and induction of apoptosis. So I'll leave it there. It's in sort of an encouraging study that's progressing now, and we're trying to take the next steps really. And we've shown, I guess, that FA3 is elevated in both adult and pediatric. We know we can target it specifically. We know from our human trials it appears to cross the blood-brain barrier, at least in recurrence. We're investigating further antibody-drug conjugate. I know that several groups around the world are working on CAR-T, and we're currently now looking at further study of the resistance mechanisms. Really haven't got enough time to go into that today. So that just leaves me to thank my hard-working group, and particularly my scientific and clinical collaborators here in Australia and funding bodies. So thank you.
Thank you very much, Brian. That was... Hello?
Yeah, we can hear you.
Yeah.
Go ahead.
Yes. Yeah. So that was very helpful, and especially the part where you also mentioned that it's not just relevant in adult brain tumors, but also in pediatric brain tumors. And it would be really interesting to follow the progress of your brain lab and see where this leads to. As I said, we'll take the questions in the end, and I'm asking Imran now to call our next speaker.
All right. So next we have Dr. Chae-Yong Kim, who will be talking about clinical trials for high-grade gliomas, the basis and starting point for a multidisciplinary team approach. Dr. Chae-Yong Kim is a professor and neurosurgeon at Seoul National University Bandang Hospital, Seoul National University College of Medicine. Dr. Kim is the Vice Secretary General of WFNOS 2021 Seoul meeting and the chair of the academic committee of the Korean Brain Tumor Society. Dr. Kim?
Hi, good morning. I'm now share my slides. Just a moment, please. Just a moment, please. Sorry. Good morning, everyone, and it's a very great honor to invite you in the first meeting of the Pakistan site for Neuro-Oncology, first meeting. And thank you again, President Dr. Enam, and invite me. And today I will briefly introduce Korean own clinical trials, and each area the basis and the starting point for multidisciplinary tumor approach, especially the PA Snow, is a first starting point. So I will show my Korean activity of the Korean Society for Neuro-Oncology and Korean Brain Tumor Society. Nothing to disclosure. And first of all, congratulations to the PA Snow. And for the success of a multidisciplinary Neuro-Oncology Society, it may be essential to do the country own clinical trials for glioma or other brain tumors, lymphomas, metastases, or other malignant brain tumors. To do this, it will be mandatory to make several disease-specific committees and to encourage a multidisciplinary team approach. So active anticipating the global multi-nation clinical trial, especially phase 3 studies, will be very helpful to set up the clinical trial assisting system and to standardize each institutional protocols, MRI, the lab, or the radiation therapy protocols, and to get society members' attention. For example, 2008, centric study by URTC was very helpful in Korean society. So K-SNO is 10 years old, and the KBTS is 30 years old. The society have done many Korean-owned clinical trials, and now many clinical trials ongoing and multi-center retrospective analysis, as well as active participating international trials. K-SNO have recently established our Korean guidelines for gliomas. You can see the right side is a Korean guideline, the glioblastoma, and then we subsequently published the guideline for grade 2, grade 3 gliomas. And left side, this is the one of the example and multi-center data collection and retrospective study, and we established the Korean own data for glioblastoma. And this one is the recently published paper, is the one example of a multi-center study, co-working. So today I will introduce 3 clinical trials data, and I'm involved in the PI. As one is a Korean study, second is a Let's Go study for newly diagnosed glioblastoma, and third is actually not Korean owned, but EF14 study you know very well is using tumor treating fields, and we Korean institutions are very actively in anticipating, and we have just published the paper in Korean patients subgroup analysis. First is the Korean study. This is the first multi-center prospective clinical trials for grade 3 gliomas of Korea. So this is a preliminary report. I just published this year, and I will show you briefly this study. You know very well, the WHO grade 3 gliomas have no definite consensus regarding the standard treatment. In this study, we designed only 2010, and so is not applied to new classification. And then this is the paper I published a few years ago, and it's a preliminary study, but just investigated, initiated study. So I did STOOP regimen for grade 3 glioma patients. So in this paper, so STOOP protocol for WHO grade 3 glioma was relatively safe and tolerable, especially non-co-deleted patients. It showed the possibility of achieving favorable results compared with those of historical control. So basis of this paper, we made a subcommittee in the K-SNO and the grade 3 glioma committees, and we have several meetings, and then we established the study. Is the phase 2, randomized phase 2 study. Because the grade 3 glioma is less frequent than the glioblastoma, so collecting the patient is very difficult. So we decided to randomize the phase 2 study and the nationwide study. So we first treatment arm is the two regimen, and second arm is the radiation therapy only group. So measuring radiology response is a RANO criteria, and safety using a CTCAE version 4. This is the protocol. It's the same as those two regimen for glioblastoma. We did 6 cycles of temozolomide after radiation therapy, concurrent chemoradiotherapy. So primary endpoint was the 2-year progression-free survival, because is the problem with the fund. And we use national fund, so we have to report the results. So the primary endpoint was the 2-year progression-free survival, and second endpoint was the overall survival. And this is the diagram, and we collected 147 patients in 4 years, and it's very difficult. And then finally, we analyzed the 84 patients. And this is the basic demographics of the patients, and then mean age was 44 years. So 2 groups that were balanced across treatment groups and baseline. And this is the treatment, and the MGMT and IDH1 mutation status is well balanced across the treatment group baseline. Actually, this study was designed in the before 2011, so WHO 2007 classification was applied basically. So, and then this is details of a treatment and the treatment group and the RT only group. You can see the very similar data of response and then follow-up data. So this is the result, and the 2-year progression-free survival. You can see the treatment group, the treatment using CCRT and temozolomide was the excellent data of 2-year progression-free survival. But this is a short follow-up data, so there is no differences in the overall survival. You can see that this is the progression-free survival data, and every 3, 6, 12 months, and then we did the Cox proportional hazard model, detecting the prognostic factors. One thing, IDH1 mutation status was a very strong prognostic factor, and second one is the age. And this is the Kaplan-Meier estimation of progression-free survival and overall survival according to treatment and MGMT methylation. But there is no statistical significant differences. This is the graph of the according to IDH1 mutation status. You can see that there are significant differences between IDH1 mutation group and wild type group, regardless of the treatment modality. Arm A, Arm B, same result was shown. Here's a progression-free survival to IDH1 mutation. It is figure A is the total group, figure B is the treatment group, and figure C is the control group, but same result. There are significantly, statistically significant the data. It's overall survival data, it's the same thing. And then it's a graph table, and then MGMT methylation status, there are no significant differences. You can see the a slight different overall survival, however, statistically non-significant, because this is a very short time follow-up data. So we are now following the patients. This is the in terms of safety, the toxicity data. There is a greater than grade 3 events, only 2 patients, thrombocytopenia and leukopenia. So summary in the Korean study, temozolomide during and after radiation therapy group improved the 2-year progression-free survival in Korean patients with a newly diagnosed non-co-deleted grade 3 gliomas. IDH1 mutant was the significant prognostic factors. And patients with IDH1 mutation had a significant survival benefit regardless of the treatment. And very longer term follow for survival analysis will be mandatory, and the case note study group will show you the result in future. A second study is a so-called Let's Go study, is a KBTS 1601 study, is the glioblastoma, and we using the levetiracetam, so-called Keprad and anti-epileptic drugs as a sensitizer of the temozolomide. So it's I'm as a PI, and then this study, the aim is the survival benefit of levetiracetam as a chemosensitizer of temozolomide for patients. This is the background, and you know very well this paper. 10 years ago, Dr. Popust published preclinical study data. They showed the levetiracetam inhibits malignant glioma cell proliferation and increased glioma cell sensitivity to the monofunctional alkylating agent, the temozolomide. So I did, in my institution, I did a prospective study. And so I published the 5 years old the journal Cancer, and the survival benefit I approved. So the median progression-free survival and overall survival of the patients who received the levetiracetam in combination with temozolomide were excellent. Then another, not using patients. So they are using valproic acid or another anti-epileptic drugs. So we proved this in our single institution data. So basis of this paper, we made a committee, and we designed the prospective open-label, the multi-center code trial of validation of this, the role of the levetiracetam as a sensitizer. So with the primary endpoint was 6 months progression-free survival, and secondary endpoint overall survival. This is a diagram and study design, and we overlapped the stool regimen using levetiracetam preclinically, pre-surgery period to the end of the treatment. So this is the material result, as is Bayesian demographics, and then the result was excellent. And now we are manuscripting now and under submit and under review. And this is the progression-free survival was 13 months, and median survival was 29 months. It's compared to our Korean-owned multi-center study data. Is our data published 2017, progression-free survival 10 months, overall survival was 17.5 months. So compared to compare this data, the addition of levetiracetam during concurrent and adjuvant temozolomide along with radiotherapy in patients with newly diagnosed glioblastoma may result in improved outcomes compared to historical data and merit for the study. So it's a third one is the Korean subgroup analysis of the Korean patients in the EF14 study. And just published in this year is the result of EF14 study, you know very well. And back-to-back pattern, I also involved in this paper and the quality of life. And I also published the data, and increased compliance was very related to improved survival. So today I will show you the Korean subgroup analysis. You know very well, Tumor Treating Fields is a non-invasive anti-mitotic cancer therapy and comprising a low intensity, intermittent frequency alternating electric fields. So now Tumor Treating Fields are approved in the United States and Europe, and in Asian country, Japan and Hong Kong is approved. And I know that China now is preparing. And this is the diagram, though you can see the action of a mechanism of the Tumor Treating Fields. And this figure is my patients, and left side is the set of Optune. And you know very well this data, the phase 3 EF14 trial data, and Dr. Stu reported 2017. This study showed that Tumor Treating Fields extended the median overall survival ever very longer to 20 months, and compared to a standard treatment group in 16 months. And systemic adverse effect was occurred in 48%, and control was 44%, very similar, and statistically no differences. However, One thing, skin toxicity occurred in 52% of patients receiving tumor treating fields. However, severe, more than grade 3 skin involvement occurred in just only 2%. So now we analyze the Korean population. 39 patients were involved in this study, and tumor treating fields were applied to 24 patients, and standard group was 15 patients. So I analyzed the two groups, and then our subgroup data, and then this left side is EF protein study. So baseline characteristics were well balanced in two arms and comparable to the EF protein study population. Interestingly, skin irritation was slightly less frequent in Korean patients compared to overall population. Less than 30% complained of skin irritation. EF protein was 52%. And tumor treating fields and another adverse effect events of two groups are similar data. And overall survival, you can see the very excellent data in Korean subpopulation. We showed 27 months compared to standard group, 15 months. So you can see the very excellent data using tumor treating fields. Interestingly, the difference in survival rate was higher in tumor treating field treated Korean patients compared to the same group of the EF protein population. You can see the 1 year survival rate was more than 95% compared to 73% in EF protein study. And 2 year survival rate was almost 60% in Korean patients, but compared to 43% in EF protein study. No significant difference in the radiology response rate between two arms. It's the same thing in EF protein study. So in summary, Korean patients with newly diagnosed GBM treated with tumor treating fields is a very similar clinical benefit, and less than 30% report skin irritation, and some are lower rate than in Caucasian patients. Then median overall survival was significantly longer among Korean patients. And these results demonstrate the safety and efficacy of tumor treating fields in Korean patients. Maybe I think same as in Asian patients with newly diagnosed glioblastoma. So multi-center study and data analysis of Asian countries might be mandatory. In summary, I hope the PA SNO be the leading group of the South Asia in the field of neuro-oncology. And yesterday you discussed much, and today Dr. Jalali showed the networking and the co-working of the ASNO countries are very important. So I hope KSNO and PASNO have a close relationship and do many co-works together. I hope so. And it's the last slide, and I'm the Executive Secretary General on the 2021 WFNO meeting. But COVID-19 outbreaks, we decided to postpone this WFNO meeting 1 year later to 2022 March. So I hope next year, 2022, we can meet not online, the face-to-face in Seoul. I hope so. Thank you so much.
Thank you, Kim. Yes, we look forward. We'll all be there.
Inshallah.
Yeah.
Thank you, Dr. Kim. I really liked how you name your trials, Koreana and Let's Go. But very interesting to see your results with the levetiracetam and how it impacts your outcomes. Once again, we'll be taking questions in the end. We have two more speakers before we go on to the questions. So Imran, over to you, please.
Yes, so the next talk was supposed to be delivered by Dr. Chen Song-Ping, but unfortunately, due to health reasons, he couldn't give the talk. Instead, we have Dr. Du-Pei Li, who's going to be presenting on the topic of precision medicine for glioma patient in China. Dr. Du-Pei Li is a resident neurosurgeon at Sun Yat-sen University Cancer Center, Guangzhou, China. He completed his PhD at neurosurgery from Southern Medical University and completed surgical residency training in 2020 from Sun Yat-sen University Cancer Center. His field of interest is surgical neuro-oncology and translational research in brain tumor, especially immunology and immunotherapy for gliomas. We are grateful to Dr. Lee for joining us at such a short notice.
Thank you for the professor's invitation and introduction. Can you hear me and see the slide?
Yes, we can hear you.
Okay. I'm Dr. Li Depei from Sun Yat-sen University Cancer Center from China. It's a great honor for me to attending this meeting. I will introduce the experience to treat glioma in our center for Professor Chen Zhongping, the chairman of Chinese Society of Neuro-Oncology. Firstly, I will simply introduce the history of Chinese Society of Neuro-Oncology. CSNO was founded under the Chinese Anti-Cancer Association in the year 2004. At the early 2000s in China, the treatment for CNS tumor was mostly administered by neurosurgeons and pathologists, and radio-oncology are also very active, but medical oncologists were few involved. Because in history, the efficacy of chemotherapy for gliomas and other brain tumors were controversial due to the blockage of chemotherapy agent by the blood-brain barrier and the insensitive of brain tumor to chemotherapy. Dilemma of the development of neuro-oncology at that time in China was the less attention paid to the chemotherapy. We lack specific neuro-oncologists and there are few well-designed clinical trials. We have ever conducted a literature analysis to review the development of chemotherapy for glioma in China. A total of 210 papers was identified up to the year 2011. Publication on chemotherapy for glioma in mainland China began in 1917, and the publication number was rising over time. Since early 2000s, temozolomide, TMZ, has been used to treat glioma in China. But most of these studies were retrospective and single institutional experience. Based on this situation, Professor Chen Zhongping and other senior experts advocated and established CSNO in 2004. The mission of CSNO are to promote the standard care for patients with CNS tumor, to promote the education and research in neuro-oncology, and to promote international communication and collaboration. After decades of development, CSNO now have more than 3,000 members, and many local neuro-oncology societies have been set up. CSNO published and updated series of clinical guidelines and textbooks for CNS tumor in China, and regularly hold training courses and education meetings. Next, I will introduce the treatment pattern and experience in treating glioma at Sun Yat-sen University Cancer Center from 2003 to 2016. More than 4,000 operations was completed at our center. Without that, glioma was the most common type of CNS tumor, accounting for about 30% of all cases. After surgery and pathological diagnosis, molecular tests need to be done to determining further treatment. This is a case of GBM, molecular marker such as IDH mutation, P19Q deletion, MGMT promoter methylation, third promoter mutation, and EGFR amplification was tested for making precise diagnosis. For new diagnosis, high-grade glioma or low-grade glioma with high risk of progression. If chemotherapy needed, TMZ is now the first choice. Genetic sequencing and gene panel testing can provide more information to guide gene-targeted therapy. In this case of GBM, high mutation burden was found and indicated of sensitive for immunotherapy. In current China, regional medical center and many commercial companies can provide service of molecular and genetic testing. For cases with anaphylactic MGMT or TMG resistant, in vitro chemotherapy sensitive assay is another choice to screen chemotherapy agent for individual treatment. Clinical trial is also recommended for patients with no standard treatment. This is a list of partial clinical trials regarding glioma we initiated, including chemotherapy, target therapy, and immunotherapy. VAL-83 is a novel cytotoxic agent with potential to treat glioma. We designed a trial to assess the efficacy of VAL-83 for MGMT ameliorated GBM, and the halfway result so that the median PFS of 22 patients recruited in this trial was nearly 10 months, which was better than historic data. In addition, we hold MTT consultation every week to discuss the best treatment strategy for the patient. However, due to the unbalanced development of the economy, patients in China are not always follow the standard treatment. Chinese brain tumor registry and survival database are not yet mature. So we conducted a retrospective analysis to review the real-world treatment and survival outcome of over 1,000 glioma patients in our center. In fact, that the reported patient survival between clinical trial and real-world data are quite different. For instance, the 5 years overall survival of GBM patients who received irradiation and TMD chemotherapy in the EORCT trial was 9.8%. But population basic registered data show that the 5-year survival of GBM is only 5.5% in the US and 10% in Japan. This registration study includes 1,001 new diagnosis glioma patients who received surgery and adjuvant treatment at Sun Yat-sen University Cancer Center from 2000 to 2015. Among these patients, there are 365 grade 4, 239 grade 3, and 307 grade 2 glioma. The majority of patients aged from 20 to 6 years old and patients more than 6 years old accounts for 14.6%. Most of the tumor located at hemisphere and less than 6 cm. After surgery, most radiotherapy was given and a dosage of 40 to 60 gray. Neutropenia and dysplastic were the main chemotherapy regional before 2008. Since that, TMG became the preferred agent for treating glioma in our center. And some patients received molecular target therapy, such as VEGFR inhibitor. This is a summary of the surgery and post-operative treatment the patient received. The extent of tumor resection was confirmed by post-operative imaging. Total tumor resection was achieved in about 50% to 60% of all patients, and more than half of the patients in this cohort received adjuvant treatment. After a median follow-up of 15 months, median overall survival of low-grade glioma was not reached, and 43 months for grade 3 glioma, 17 months for grade 4 GBM. Among GBM patients, younger age indicated better survival. Median overall survival was 23 months for patients younger than 40 years old and 14 months for patients more than 60 years old. Survival analysis found that for grade 2 glioma, patients' age, KPS score, preoperative seizure, tumor pathology, Ki-67 index, and the extent of tumor resection were independently associated with overall survival. For high-grade glioma, in addition to age, seizure, pathology, and extent of resection, post-operative treatment were also an independent predictor for better survival. We then perform stratification analysis to assess the prognosis value of post-surgical treatment in different subgroups of patients with high-grade glioma. According to the WHO grade, patient's age, and extent of tumor resection, we see that the post-surgical treatment prolonged the survival of patients in each group. 195 patients with GBM received adjuvant treatment in this study, and the median overall survival was 22.6 months, which was better than published data. This can be partially explained by that patients in this cohort were relatively younger, and the ratio of tumor total resection was higher. The patient may also benefit from the comprehensive and individual treatment that we recommended. In conclusion, although guidelines provide standard and useful guidance for the best care of patients with glioma, not all the patients follow guidelines. Comprehensive and personal therapy may be more acceptable and result in better outcome. Lastly, I appreciate Professor Chen Zhongping for his recommendation and my colleagues for their help. Thanks for the listening. Thank you.
Thank you, Dr. Dipili, and we're so grateful that you could come here and present with this last-minute request. And we hope Dr. Shen Zhongping starts feeling better. And please send him our regards. So for the last speaker of the day, I'll request Imran again to introduce them, and then we'll go on to the questions.
Okay, so next up we have Dr. Ishaq Khan, who will be talking about the association of ABCG2 and ABCB5 expressions in primary brain tumors with chemotherapeutic sensitivity. Dr. Ishaq Khan is currently working as assistant professor in the Department of Molecular Biology and Genetics at Khyber Medical University, Peshawar. In 2017, Dr. Ishaq established a cancer tissue culture facility and developed a research group called Pakistan Neuro-Oncology Research Group, PKNORG.
Thank you so much. Is my screen shared? Does everyone can see that?
Yeah.
Okay.
Yeah.
So first of all, good morning, everyone. And thank you so much, Professor Anam, for giving me this opportunity to be talking among some of the great speakers. Some really good topics has been presented so far. However, all of the work that has been presented so far was mostly on the clinical trials. My work goes back to the preclinical trials, where specifically I'll be covering one of the specific research that we are conducting. It's not completed yet. I just wanted to share this opportunity to be discussing about the research that we are doing right now in our lab. So my topic is the association of the ABC transporter, the ATP binding cassette transporter's expression in brain cancer with the chemotherapeutic sensitivities of cisplatin and methotrexate, either alone or in combinations with the ABC inhibitors, specific inhibitors. So first of all, I start to begin with the brain cancer facts. Like we all know that cancer is increasing day by day. And as per the WHO report back in 2012, it said that 8.2 million people died from cancer. But interestingly, if we see at the predictions in 2015, the new cases will be 19.3 million, out of which 11.5 million of people will die. So brain cancer survival rates have barely increased in the last 30 years if we compare with other type of cancer. So if we just see the prostate cancer survival rate has improved in 36% of patients, but the brain cancer in the last 30 years is just only 1%. So brain cancer kills more children than any other disease. So as per my own research, I was looking into the GloboCan statistics. I found that the brain cancer cases has increased, but most alarmingly, out of 3 patients, 2 are dying. So the CNS cancer is the 10th leading cause of death for men and women. And it is estimated that in this year, 18,020 adults will die from primary CNS tumor in the year 2020. And the 5-year relative survival rate is different from different type of cancers. But interestingly, it's very low for the glioblastoma. So the background of my topic is that I wanted to focus on the major issue, which is that since the last 7 decades, the chemotherapeutic resistance was experimentally documented. It still poses a major challenge in cancer treatment. So the chemotherapeutic drug resistance is one of the major failures in complete eradication of brain cancer. So such failures are correlated with the existence of several factors, but the major ones are the presence of ABC transporter proteins and the presence of cancer stem cells. So the evidences of ABC transporter proteins' strong association with the chemotherapeutics resistance are growing. And what we are planning in this study is that if we use specific inhibitors that can target these ABC transporter, it will improve the overall clinical outcomes. So for this purpose, the objectives that we developed was that obviously the first thing that we thought of was to establish a primary brain tumor cell lines bank from our local population. And we wanted to cover it from the surrounding populations who are coming to the Pakistan, from Afghanistan, and from Iran. So we wanted to cover, we wanted to generate the cell lines from these 3 countries, Iran, Pakistan, and Afghanistan. Why it is interesting and why it is necessary to generate the primary cell lines. I think Professor Brian has covered that part as well, but let me cover it in general. A lot of research has been conducted on the commercial cell lines, for example, the malignant glioma UHE7 cell lines. However, the most important problem with that using the commercial cell lines, it does not give you the real picture of what's happening in the patient's body. For example, if we culture the cells, in more and more passages. As the passages grows and grows, it acquires a lot of mutations, and those mutations are not originally present in the patient's body. So that's why the primary cell lines actually gives you kind of a real image of the patient body. So it kind of depicts the exact replica of the cell lines that's there in the human body. So another objective was to detect the ABC transporters biomarkers in brain tumors and their association with the chemotherapeutic resistance, and to correlate their presence with the presence of cancer stem cells marker, and to study the effect of these chemotherapeutics alone or in combination with the specific inhibitors for ABC transporter proteins. In the methodology, what we did was to we have acquired the ethical approval, the consent form before retrieving the brain tumor sample. And then we distribute that brain tumor sample according to the guidelines that we have developed for our brain cancer tumor bank. So we separate tissues, we cryopreserve the tissues, we cryopreserve the blood, and we generate cell lines. And then those cell lines are being used for different type of studies that I'll be covering now in this specific experimental study. So the anti-cancer potential of the cytotoxic drugs, which were the cisplatin and methotrexate, they have been enhanced using the inhibitors for ABC transporter in brain tumors. So if we see, interestingly, if we see the cell line, the malignant glioma U87 cell line, which is a commercial cell line, the IC50 was 133 micromoles alone for the cisplatin. However, the IC50 reduced when it was in combination with a specific inhibitor for ABC transporter. Similarly, it was observed for the methotrexate alone treatment, while methotrexate with verapamil, which is a specific inhibitor for ABCB5. But interestingly, if we compare the IC50 values for commercial cell lines versus the primary cell lines, it shows a huge difference. The cisplatin alone would kill the U87 cell line in 133 micromole of dose, but the same same drug will kill a primary cell line at 356 micromole of dose. So this clearly indicates the difference between using the commercial cell lines and the primary cell lines. Interestingly, what we thought is to look afterwards the expression of ABC transporters after the treatment with chemotherapeutic alone or in combination with the specific inhibitors. And interestingly, if we see this diffuse glioma cell line, the control was the percentage expression of APC2 was higher compared to the treatment with a chemotherapeutic alone. But when a specific inhibitor was added, then the survival fraction of the cell lines reduced, as it can be seen in the immunofluorescence images here. This is the control, this is the cisplatin alone treatment, and then this is the pantoprazole. So similar observation was observed for the ABCB5 expression. Now, interestingly, we wanted to see whether using a computational docking method to see whether this interaction is real or whether this interaction is happening. Do they have any kind of a homology modeling data to come out with? So taking together the binding of pantoprazole and the transport site of ABCG2, which is the cavity one side or in vitro result, it can be assumed that pantoprazoles possibly inhibit the ABCG2 expressions. Similarly, the ABCB5 expression was also docked with the verapamil, but the ABCB5 human transporter protein structure is not solved yet. So we have developed its homology protein model using a template that was acquired from the PDB ID with this one. So this observation also supports our experimental data where inhibition of ABCB5 with verapamil has shown reduction in the multi-drug resistance of ABCB5. So this is the table where we can clearly see the binding energies for using the pantoprazole and verapamil. That the binding energy is to this, which indicates that it has stronger affinity to bind to these specific ABC receptors. Now, interestingly, we wanted to further confirm that because when we generate the cell lines, these cell lines from the patients in these initial passages show different behavior. But as these passages grow for a period of month or 2 months, we observe a morphological changes in these cell lines. So we wanted to see what type of specific morphology these cells adopt as they grow further. And interestingly, in the week 1, there is different type of morphologies, but as the week 2, different morphologies are adopting. So at the end, mostly we see a B and D type of morphologies, which is kind of a glial, bulky cells, and the bipolar neuronal kind of a look morphologies. And we wanted to correlate these morphological profile with the presence of ABC transporter and with the presence of cancer stem cells markers. Similarly, we wanted to see whether the effect of the media to influence the morphological profile of these cell lines. We did a bit of modifications in the media, and we wanted to see whether it can affect the morphological profiles. But interestingly, even changing the microenvironment for the cells, they are predetermined to acquire a specific type of morphology, which were mostly D type for the specific cell line and the B and D type for another cell line. And then later on, we wanted to see the expression of the cancer stem cells markers. So the glioblastomas cancer stem cells marker are mostly the CD133 and SOX2, which is widely used. So we try to look and correlate the presence of these CD133 and SOX2 expression presence with the chemotherapeutic resistance and also to correlate these with the ABC transporter proteins. So these were specifically about the presence of biomarkers in the brain tumors. So as Professor Rakesh has mentioned, that molecular markers are changing the landscape of neuro-oncology. This is indeed very right, because different biomarkers, like Professor Tom has mentioned, that the IDH1 mutation was not originally considered that it will play any role in the prognosis, but now it's being used for the prognostic outcome of the GBM patients. So these biomarkers has to be validated before in the preclinical in vitro studies. And we are now moving forward toward the in vivo trials, preclinical in vivo trials, where we have preliminarily developed the intracranial brain tumor model, a mice model. And in the parallel, we are conducting a study with one of our collaborator institute, the NUST, National University of Science and Technology, Islamabad. So where we are correlating the depression with the development of brain cancer. And we have interestingly developed a brain tumor model already, which probably we'll be using the ABC transporter inhibitors nearly very soon. So in conclusion, the ABC transporters, the inhibitors, they increase the efficacy of anti-cancer drugs, the cisplatin and methotrexate. And the high dose of methotrexate is required to achieve its effectiveness concentration in cerebrospinal fluid, which limits its use in the treatment of brain tumors. Similarly, cisplatin-induced neurotoxicity, they often result in dose reductions or withdrawal. So the use of ABC transporters and concurrent use with these anti-cancer drugs will not only enhance their penetration across the blood-brain barrier because of the presence of these ABC transporters in blood-brain barrier, but they can also reduce their dose, lowering their side effects and increase patients' compliance. So at the end, thank you all, and I'm specifically thankful to our collaborators, the Professor Shaili from Hyderabad Medical Complex and Dr. Tariq Hashim from Northwest General Hospital. These are the neurosurgeons who are providing us the brain tumor sample. And our collaborator from NUST, Dr. Anila Javed, she's just back from Harvard Medical School, one of our renowned scientists in cancer immunology. And our international collaborators, Dr. Dima Hossain and Professor Steve, who were my supervisors, and they are providing us every help to make this lab a success. Thank you all.
Thank you, Dr. Ishaq. And so exciting to see such great work being done so close to our own hospital. And we really look forward to collaborating with you and your lab. And I can also tell you that Dr. Athal has been secretly admiring the quality of your slides. So very well presented and very, very exciting work. So with this, this session is concluded, and I'm going to start with the questions. I'll just confirm whether the speakers are already here. Tom, are you here?
I'm here.
Dr. Vinny Santosh, Rakesh Dalali.
Yes, I'm here.
Yes, I'm here.
Dr. Brian Day and Dr. Kim had to leave. Dr. Lee, are you here? Okay, so I'll start with the questions. I'll in no particular order. So if any one of you would like to take up these questions, you're most welcome. So my first question is, how far are we from treating brain tumors, mainly on radiology and serological workup without the need of biopsy? Maybe Rakesh or Tom would like to answer that.
Well, I could certainly begin. I think obviously the primary diagnosis and decompression for neurologic relief is critical. So I think to do entirely without resection is going to be the minority of cases in perhaps unreachable locations. But the surgeons will tell you there's no such thing as an unreachable location. It's just a matter of relative risk. I think, however, for the serial follow-up, I think that's where there's some of these less invasive monitoring is going to really hold its own.
Okay. We have a Professor Abdul Karim from Taylor University in Malaysia. And I can tell you from my previous sessions that I've chaired that he's following us regularly, and he's been throwing questions after questions at us. So thank you very much for your interest, Dr. Abdul Karim. And Dr. Abdul Karim wants to know, are tumor markers also useful in low-grade gliomas? And what happens when there's a cytoconversion? They change into high-grade gliomas. In that scenario, can we rely on tumor markers alone to monitor these patients?
By tumor markers, are you presuming that these are markers of the tumor in a resection specimen, or are we talking about circulating biomarkers?
I think he's talking about circulating biomarkers.
Yeah, I don't think we know. These are just early days in the context of glioma, and obviously the teams that will be necessary to compile data in aggregate are going to be critical. So I hope so, but I don't think there's any data to suggest that at this moment.
Okay, I'm not sure if this is the right forum for this question, but it's a good question. Should hemorrhage be included in volume when treating brain mets? And this is in reference to radiation therapy and SRS.
So if it is a part of the tumor and it has clearly bled, and mostly the bleeding is because of the tumor tissue, as you know, certainly when you operate upon it as well. So typically we would include it in the field unless there's a clear-cut solid nodule and there's a fluid level which has absorbed over a period of time. But typically, to be on the safer side, it is better to include the hemorrhagic component of the tumor as well.
But typically also you would delay the radiation long enough that the hemorrhage would subside.
Yeah. But sometimes, you know, in renal cell or choriocarcinomas, you have to treat very quickly. You can't wait for too long in a metastatic setting, and you cannot operate. So it's a case for radiosurgery. So there, you know, sometimes we do see these type of situations.
Okay. Next question is the response of macrophage population the same in immunocompetent versus immunocompromised patients? Dr. Winnie, Dr. Any takers for this?
Again, from my point of view, it's perhaps too soon to tell. I think certainly the animal models have historically not enabled us to look at the dynamics of the immune cells, only because of the immune suppressed nature of the animals. In the patients, I think we're only coming to recognize the M1, M2 phenotypes of macrophages, and more exploratory studies need to be done. Again, we're dealing with incomplete data. I'm sorry, but that's always the answer, but I'm sorry, that's the truth.
And Dr. Kim, spoke to us about his Let's Go trial and Koreana trial, and it was interesting to see how levetiracetam is influencing treatment. And we at AKU are not using any other anti-epileptic other than levetiracetam, especially in adult patients. How's your experience, Dr. Tom and Dr. Rakesh, with levetiracetam as a, and do you think that, what's your experience with the anti-epileptic itself and its role on influencing the response to chemotherapeutic agents?
You know, there have been reports that agents such as valproate has some biological effect as well in the anti-tumor sense. The levetiracetam effect is probably relatively small, but again would be teased out only in a prospective trial. So the question really comes down to how significant is the impact to justify going ahead and doing such a trial to tease out that increment. And I'm not certain how large it is. We use Keppra as our first line agent, so it's pretty common. So if there's a benefit, I guess we accrue that benefit. But the question is, how much do you want to tease it out to quantify? Because I suspect the effect is likely quite small.
So I agree with that as well. We also use levetiracetam as the first line agent, practically throughout the country now for the last maybe 8-10 years. Because of the safety profile and so on and so forth. I again echo Tom's view that the anti-neoplastic activity is hitherto largely unknown. Valproate got everyone's attention because of its HDAC inhibitor property and also some anti-angiogenic properties. But largely anti-angiogenic therapies have not lived up to the promise, so it's kind of fallen off the radar. I know NCI was trying to do some study on the valproate. We also tried to do a small study on valproate. But if we have to change from levetiracetam, then we do sometimes consider valproate for whatever benefit it might have. And finally, we have some metronomic protocols, and these are relevant from resource constraint settings as well, with a combination of several chemotherapeutic agents, especially in childhood brain tumors, in long-standing DIPGs or ependymomas who recur, especially the PFA types, or even some metroblastomas we have accrued over a period of time, a metronomic regimen. And there we do incorporate valproate as one of the agents along with the other chemotherapeutic drugs. And there, interestingly, for the anti-neoplastic activity as compared to 50 to 100 units per, which is the usual therapeutic range for anti-convulsant effect, for the HDAC inhibition, you need about 100 to 120. So you have to give slightly higher doses for valproate if you want to derive any anti-neoplastic benefit whatsoever that might be.
With the additional risk of the side effects of such a high dose?
There is a bit of side effect, but we have used it extensively in children. And we have a publication also. There's actually a randomized trial going to start on metronomic therapy in refractory high-grade medulloblastomas in Mayfield institutions in Mumbai. So far it's not been so bad.
And it also makes sense that if you have a first-line anti-epileptic, which has such a high safety profile, you can't really replace it for a trial and try something else. So you can't really find a control group to compare it with. So my last question is with reference to precision medicine. So Tom, you'll have to answer it. How long does it take to run all the tests before you can customize treatment for a brain tumor patient?
Right. So the turnaround time for some of the larger panels, and even now they're actually generating clinical exomes, the turnaround time is in the 1 to 2 week time range, which is in the immediate perioperative recovery period as we arrange radiation treatment. Unfortunately, unlike in lung cancer and prostate and other solid tumors, the hit rate for identifying actionable mutations based on large panels or exomes is still relatively small. So there are other data that must be used in a correlative way to identify signatures, perhaps not monogenic mutations, but perhaps signatures or patterns that might guide therapy for prospective trial. So in practical reality, the turnaround time for molecular testing is not the rate limiting step. It's really the sparsity of the numbers of matches of drugs that we have to those specific mutations. We can generate large panels, no problem. The question is, and the problem is, we don't have yet enough tricks in our bag, unlike the lung cancer patients where you're almost guaranteed to have a hit and an actionable mutation in non-small cell lung cancer. So we're very jealous of the lung cancer oncologists, but we're getting there. And there are other layers, whether it's an expression array, whether microRNAs and some of the non-coding patterns, these correlative studies will generate then new prospective hypotheses that'll enter into clinical trials, including some of the dynamic trials that we talked about.
So how much longer before we can have it as a commercially available option for even countries like Pakistan and India?
Oh, well, like I said, there are any number of companies that have commercial product now, and certainly laboratory developed tests as well to do some of the intermediate sized panels. Some of the 50 gene panels, in fact, have the vast majority of actionable mutations as single genes on them. We tend to think that the more comprehensive products, including the exomes and beyond, may have more data, but again, that's data for discovery, not necessarily for action today. So those panels, those are routine in pretty well most oncology centers now, certainly for all solid tumors, brain tumors included. The problem is not so much the lack of testing, it's the lack of the match of the testing with the specific therapeutic.
And it will be the cost also that we, that will be
yeah, the cost is dropping, certainly the smaller panels. What we have a problem in US is the reimbursement. The cost, the unit cost is actually quite small, but just nobody wants to pay for it. As far as the insurance providers, but they're coming to recognize the more efficient we are with choosing more effective therapies, the improved clinical outcomes pay for the original test costs. The question is, where do you accrue that cost to? Upfront cost to long-term benefit. That's really what the model is.
Can I just make a comment? So we have the same experience in India. We frequently use the focus assays, just the 52 gene panel. It's called OncoMine. And that not so much, unfortunately, in brain tumors, as Tom rightly said, because there is not so many drugs available. But in other sites, and occasionally in brain too, we do use them. That costs only 35,000 Indian rupees. I don't know how much it costs in Pakistani rupees. So it's not so much, given the fact that what are the other therapies involved. But if you do the whole genome sequences, like 300, 400 genes in the NGS platforms on Foundation One and MedGenome and KDs, that obviously costs more than 1.5 to 2 lakh rupees, and that's a substantial amount of money. It has made remarkable progress though in lung cancer, kidney cancer, sometimes in head and neck cancers. And we're just hoping and hoping that it would translate in neuro-oncology too.
Yeah. Those costs would be worth it, frankly, if there were specific therapeutics, but there just isn't yet. It can't be justified just yet.
That's right. That is true.
It's hopefully just a matter of time.
Correct.
And hopefully we'll see this the result in our own lifetimes. So just to wrap up, we had an excellent session today. Dr. Tom Mickelson talked about cancer genome atlas and precision medicine. An excellent keynote speech for this session. Dr. Vinny Santosh spoke to us about glioma classifications, especially the WHO's 2016 classification and its implications in management. Dr. Rakesh Jalali spoke to us about molecular markers. Dr. Brian Day spoke to us about his experience with using EFA3 as potential target. Dr. Chae Yong Kim shared his experience with the Koreana and the Let's Go trial for high-grade gliomas. Dr. She Zhongping couldn't come, but Dr. Lee, on his behalf, spoke to us about precision medicine and his experience with setting up a specific oncological practice in his center, and his experience with the brain cancer care around where he works. And finally, Dr. Isha Khan spoke to us about ABC transporters and their lab experience with the initial lab experience with the difference in outcomes. And in the end, I would thank everybody once again for a fantastic session. And with this, we will conclude this session. Thank you very much.
Thank you.
Thank you.